Our program today is packed with insightful talks and discussions led by some of the most eminent minds in the field. We are honored to have Dr. Sandeep Agarwal from Fortis Noida kickstarting our event with a discourse on navigating complexities, addressing contemporary challenges in cancer treatment for patients in Western Uttar Pradesh. This session will be chaired by Dr. Rekha Gupta, Dr. Tripti Saxena, Dr. Santosh Singh, and Dr. Shweta Agarwal. I welcome you all to the stage.
Okay.
Good morning, everybody, and thanks to the organizer for this wonderful event. And first of all, I would like to introduce Dr. Sandeep Agarwal, with a rich experience of more than 30 years and at present chairman Galaxy Oncology. He is founder of Orogyam Cancer Care Clinics, and at present he is senior consultant visiting at Fortis Noida. He has been very instrumental in establishing oncology services in this area, especially in the Western UP. He is one of the pioneers who has started oncology services in this area. His passion is to provide quality care in a cost-effective way. He has established more than 8 oncology centers in this area. So he's looking forward to establish cancer centers, especially in type B cities, where he can provide quality care in a cost-effective way. At present, he is having his running centers at Hisar and Moradabad. So, over to you, because we are eager to listen from his experiences in this Western UP area. Over to you, Dr. Sandeep.
Yeah. Good morning. Good morning, chairpersons. Thank you, Dr. Tripti. Good morning, delegates. And thanks the organizers to invite me and to invite me to talk on a topic which itself is very complex. If I see the topic, navigating complexities, addressing contemporary issues, challenges in cancer treatment for patients in Western UP, itself becomes a very complicated topic. So initially I was thinking what the organizers want me by restricting myself with this. Then I thought, let me try to justify the topic. And I prepared it. Nothing in Western UP can be started before paying homage to late Professor Dr. V.B Bhatnagar. He is father of oncology in Western UP. So, Sir ko naman. Now I come to the topic. navigating complexities, addressing contemporary issues, challenges in cancer treatment for patients in Western UP. So I simplified this topic in my way. Why did it simplify it? I thought the organizers wants to discuss how we are making the cancer treatment secure in this part of the world, how we are able to deliver evidence-based treatment in this part of the world, how we are delivering a coordinated comprehensive care in this part of the world or in any newly defined setup or any newly defined city. This is what I thought the organizer wanted me to talk about. So once you are coming up with a new setup, how to arrange things, how to make things, how to develop trust, how to develop faith. So this is what I thought that they want. And my one-line answer, in fact, one-word answer for all this is team. Whatever you do, whenever you are starting a new center, you should be having a great team. Only great team makes great centers. Great centers rarely make great teams. So, when we talk about teamwork, oncology is one of the most recognized disease in which teamwork has given you results, improved results. The team consists of surgical oncologist, radiation oncologist, medical oncologist, gynae oncologist, or physicians who are associated with like principal branches of surgery, pathologist, histopathologist, radiologist, nuclear medicine expert, and in fact, oncology nurses also. So before we start, and what I am saying is not without evidence. So there is an evidence for when these team works together, they deliver. And this team is known as multidisciplinary tumor board in oncology. So what is the evidence is that when the multidisciplinary tumor board, the team works together, the results are improved, there is definite increase in overall survival and decreased rate of disease recurrence compared to standard of care in carcinoma lung and carcinoma breast. This is a published data. Overall survival has also been improved in certain other malignancies in which tumor board approach has been followed, like carcinoma lung, colon, esophagus, or in metastatic castration-resistant prostate cancer. So this data is available. This data is there, which support that yes, oncology patients, cancer patients should be managed by a team. Now, going into little detail, statistics. When we work as a team and when we treat cancer patients, especially when we treat lung patient, longer median overall survival, which is approximately around 36.9 months, is around 19.3 months, becomes 36.9 months. So there is a definite increase, marked increase. Compliance to NCCN guideline, which most of us follow, improves from 80% to 94%. So within the team itself, the compliances start increasing. Then 41% of the patients had change in their treatment plan following the recommendation by a multidisciplinary tumor board. It means that if I am treating alone all the patients versus if a treatment team is treating, chances are there in carcinoma lung that in 41% of my patients, the team will give me a better treatment protocol. Similarly, in cases of carcinoma breast, the relative risk of recurrence and death was lower for newly diagnosed breast cancer patients if they remained under MDT care. It is very significant. And that navigating complexities can very well be overcome if we start a center which has a tumor board, and if we are following the advice of tumor board. Enough data is there which shows. So once combined 7 people or 8 people are taking decision, then nothing is complex, then everything is simple. And these are the results. Now this patient, if would have come to my clinic, I would have said कि कुछ नहीं करना है, आप घर ले जाओ सेवा करो. But once this patient is managed by a multidisciplinary tumor board, the results are different. You see, I'm not talking about whether patient remains, for how many times, much time patient remains, but this is the response you see. So team is something which is a must. Without that team, you cannot navigate any complexity. Now, once you are part of the team itself takes care or motivates you to do best. So, we have seen in surgical techniques, it was basically how did surgical techniques improved? Because the team wanted, multidisciplinary team wanted, or the group of doctors wanted that these surgery should be better. So surgeons shifted to less invasive and more functional preserving surgeries. Laryngeal preservation protocol came. How did it came? Because Watton group was working as a group. And Watton group thought that we can go ahead and preserve larynx. But it would have been a single person who would never thought of that. Organ conserving surgeries with plastic reconstruction. See example of carcinoma breast today. Carcinoma breast with oncoplastic surgery. Even in a locally advanced disease, this is offered. But why they are able to offer this? Because they are working in a team. They have got a support. Blood loss is less. Gone are the days in which you require for pancreatectomy 4 or 5 units of blood. Now you require 1 or 2 maximum. Carcinoma breast, no blood at all. There is no requirement of any blood. But this has happened because people have worked together and found out a way. They have navigated those complexities and found a better way of doing things. Less morbid surgeries. I don't have to tell, but those who are dealing with cancer, they understand that surgery of today is far, far less morbid than it was previously. Then we are going for sphincter preserving surgeries, indications which were not seen before. They are seen now. And they are seen only because there is a comprehensive approach. You do certain thing, I do certain thing is done by my third colleague, and we basically get a result, which is better than doing excessive surgery which was done previously. Limb preservation, functional limb preservation. Then radical cystectomy with neobladder formation. These are the things which has happened only with we working together, not I working together alone. Then let's see the second branch, radiation oncology. Dramatic things have occurred in past 2 decades. I started my career with a cobalt, and I tell you, so I started my career with a cobalt, and when I was MBBS student, in 1998 when I entered MBBS, and in 1991 when my first clinical posting took place, so I was going through a corridor which I just happened to see, and there it was written radiotherapy and radiology department in LLRM Medical College. We were posted there, but we never saw that machine. We basically went, saw some X-rays to pass the exam, taught, and we came back. Then in my internship, when I gave exam, and I got radiation oncology, that was the first time that I went in radiotherapy department and saw it. And then to my surprise, I came to know that this machine is not working for last so many years. So, from that time, I'm talking about 1991 or 94 when I cleared MBBS, to this time, in 2024, 30 years, sea change has taken place. Sea change. And why this sea change has taken place? It is because of the men, that is the radiation oncologist, the machine, the treatment equipments. They have changed. From cobalt, which was not functioning, to our super functioning accelerators, fast accelerators, which can treat 100 patients in a day. We're in that era. The indications they have changed. Now you treat so many diseases with radiation. And Sir is sitting here, Dr. Rath is sitting here, and this is the word which Sir has given us. Now we don't say that there is side effect. We say accompaniments have decreased. Radiation accompaniments, they have decreased. So we moved from 2D-RT, which was the most toxic one, to 3D-CRT, to intensity modulation, to image guidance, to artificial intelligence, stereotactic, radiosurgery, and now adaptive. So these things have taken changes. These changes have taken place in last 20-25 years. And important thing is that most of the good centers, they are practicing this. I've talked about cobalt. I started with cobalt and then linear accelerators. Now think of a city like Meerut. Meerut is a very good city, historic city. But in Meerut, we are having tomotherapy. We are having cyberknife. We are having true beam. We are having vital beam. And there are 3-4 more centers which are going to come up with something different. Now, how has it happened? It has happened only because awareness is there and people have seen results. And those results are only because of the team approach, not from a single person. So these are new indications of radiation, not going to details. Now, side by side, as these advancements took place and complexities were reduced, our supportive branches, they helped us a lot. Like in imaging, we changed from non-functional imaging to functional imaging now. And more and more work today in oncology, in imaging, is done with functional imaging. And this functional imaging part, though is very debatable in most of the conferences, but yes, in heart of hearts, we know that PET-CT has given us a tool which is better than many tools which are available. Advancement in pathology. I remember incidents when I was a child. One of my relative got pleural effusion. Relative means हमारी फैमिली के बुजुर्ग में उनको एक pleural effusion हुआ. And I'm talking about when I must be around 10 to 12 years. Months, but it was not diagnosed what was the reason of pleural effusion. And he died because of pleural effusion. Do you think today it can happen? It cannot happen today. And why it cannot happen? Because pathology has advanced. You have got molecular pathologies, you have got biomarkers, you have got gene sequencing, you can go for liquid biopsies, you have got so many new cancer markers. So this is how navigation has taken place. And most important thing, we know about cancer, biology, more than we were knew in past 3 decades. And as I was going through, so for cancer, Hippocrates proposed the theory of black bile. That if black bile is black, then it is cancer. So he was not knowing what is cancer, but he said that bile black is something like cancer. And who is having black bile will never be cured, who is having yellow bile will be cured. So and why I am telling you today here is, 2 days back I was in Hisar, and a doctor said कि तुम्हारे मरीज को ना काला पित्त हो गया है. Now he is going to die. So I remembered that and I put it here. So I asked him what is kala pitt. बोले hepatocellular carcinoma because of hepatitis C is kala pitt. So long back, but we have moved way ahead of that. We understand now biology better. And because of this understanding of biology, this navigation of complexities, decreasing complexities, we have reached a stage where we can say that now we are ready to give precision medicine to cancer patients. But remember, this precision medicine can only be given when you are a team. So, gene therapy, immunotherapy, combinations of gene therapy, radiotherapy, surgery, gene therapy, this is going to happen only when team is there. And that is the only way we can navigate the complexities of cancer in any city. The treatment will, we have established certain things. In certain cancers, we have seen that precision medicine has already been implemented, like carcinoma lung, triple negative breast cancer, pancreatic cancer, brain cancers. What we are going to see now more will be better rehabilitation post-treatment. The patient should come into the society back. So with this, I thank the organizers. I think I have justified myself with the topic which was given to me. Thank you very much.
Thank you, Dr. Sandeep, for such a informative presentation. Success of the treatment, especially in the malignant patient, lies, as you very rightly said, in the multidisciplinary, multidimensionally and holistic approach. Thank you, sir.
I think Professor Rath is having certain...
Yeah, Dr. Sandeep he didn't cover, probably he would cover after 20 years, which I will cover. The thing is about team. Team full form is together everywhere achieves more. Why? I'll tell you some part which is written in books. Most of us who work have complained. If somebody says, what? And all should use the word accompaniment, because there is no. Dr. Anurag is here. Is car following a circle? तो जादू करना पड़ेगा. इसमें very important part of it. Most of us follow guideline, but in spite of that, सबके पास एक न अगर आप टीम का फॉलो किया, सबके सिग्नेचर है, आप सब सुप्रीम कोर्ट ऑफ जैसे आप लोग सारा मिलके क्यों नहीं करते? साइन एक करने के लिए 2-4 लगा दो. अगर साथ ही जाएंगे, कॉन्फिडेंस, यू विल हैव ए कॉन्फिडेंस, मेरे पीछे तो नहीं पड़ रहा है, ये तो होगा ही। ठीक है, अब मर गया, जस्ट मर गया, कोई बात नहीं। हाँ हाँ, तो ऐसा है, टीम वर्क का बहुत बड़ा फायदा है। एंड डॉक्टर संदीप इज ए पर्सन, ही एंड डॉक्टर तृप्ति बोथ आर सिटिंग हियर, दे आर प्लानिंग ए चेन ऑफ हॉस्पिटल्स अक्रॉस द कंट्री। एक तो हिसार में लगा दिया, एक मुरादाबाद में लग रहा है, एक गाजियाबाद में लगेगा। एंड एनीबडी वांट्स एनी टेक्निकल हेल्प और एनी जुगाड़ की हेल्प कैसे करना है इंडिया में, यू कैन टॉक टू देम।
थैंक यू सर, थैंक यू वेरी मच।
We are witnessing a mushrooming of the oncology centers or cancer centers across the country, even in the suburbs, type 2 towns and type 3 towns. So one reason may be that there is an actual increase in the burden of cancer. So there is an increased demand in the society. That's why there is increase. So that may be one reason. And regarding this Hippocrates being considered the father of oncology, and he gave the name cancer, I wish to tell that Professor Shushruth in Banaras, in VHU, 500 years before Christ, he had given the word Kark Rog. He has described in Shushruth as the Kark Rog. So Kark means kekda. That word was coined by Professor Shushruth here in India, in Varanasi. Thank you.
Thank you, sir.
Thank you, sir. Thank you, Professor Srivastava, for his comments. In the, I hope, previous 15 days back, there was a news in a leading newspaper that now India has become the capital of the cancer in the world. And still, if we, whenever we discuss with Dr. Rath, there is still lacking the demand versus supply in terms of oncology setups in our country. So probably it is the need of the hour to establish, and it's the need of the hour to focus mainly on the type B cities where still the facilities are lacking. Yeah. Thank you, Dr. Sandeep, for enlightening us. Thank you.
Thank you
Thanks,
very much.
Raksha.
Thank you, Chairperson. Thank you. Thank you, audience.
I would now like to invite Dr. Arun Kumar Verma sir to felicitate our honored chairpersons.
Now I would request Dr. Titiksha Jain ma'am, Assistant Professor from Subharti Dental College, to enlighten us on our next topic of the day: can oral cavity and oropharyngeal cancers be prevented? This session will be chaired by Dr. N.K. Sahu sir, Dr. Rahul Bansal sir, Dr. Riaz Ahmed sir, and Dr. Prajesh Dubey sir.
Jai Hind everyone. Dr. Titiksha is a dedicated, accomplished oral maxillofacial surgeon with a solid academic background, including a Master of Degree specialization in oral maxillofacial surgery from A.B. Shetty Institute of the Dental Science, Bangalore, and BDS from MCOTS, Manipal. She is recognized as the overall topper in the MDS oral maxillofacial surgery department, consistently excelled in the academic achievements, securing top ranks and distinction throughout academic and professional career. Also, she is a certified tobacco and tobacco cessation specialist and envisioned to make India free from tobacco abuse. Thank you.
Thank you, sir. A very good morning to everyone. It gives me an immense pleasure to speak in front of the stalwarts of the field. I have been given the topic, can oral cavity and oropharyngeal cancer be prevented? So as we all know, prevention is better than cure. But before going further, let's have a look at these images. The images which attract the youth and influence them. But what about the aftermath? The sad reality which no one shows, which a patient goes through after falling into bad habits. So India occupies around 2.4% of the land mass in the world and is around 17.5% population of the world. So according to National Oral Cancer Registry, it is the 7th highest incidence of oral cancer is seen in India, which now, as ma'am said, India has become the capital for oral cancer. So the distribution of oral cancer, it occurs 32% in buccal mucosa, followed by tongue, lip, palate, and so on. So what are the etiology and risk factors associated with it? So the most common one, which is tobacco, according to WHO, 90% of oral cancer in India is directly attributable to chewing and smoking of tobacco, along with alcohol. And when both are consumed together, it shows synergistic effects. The other habits being betel quid chewing, personal history of head and neck cancer, nutritional deficiencies like vitamin A, C, and E, oral infections like candidiasis, prolonged radiation exposure, and chronic irritation, mainly by the sharp tooth. These all lead to the oral cancer. Additional risk factors include excessive exposure to sunlight, immune suppression, human papillomavirus, genetic predisposition, oral potentially malignant disorders like leukoplakia, erythroplakia, and the mouthwashes which contain high amount of alcohol. So as you can see, 75% of oral cancers are related to lifestyle choices. This means that it can be regarded as preventable. Coming to tobacco and its history, it was Christopher Columbus who first discovered tobacco in San Salvador. He saw that these strange leaves were traded and used for ceremonial and medicinal purposes. Tobacco was first introduced in India in the late 16th and the early 17th century, where tobacco smoking became a symbol of aristocracy with the introduction of hookah. It is chewed, smoked, sniffed, or sucked. The carcinogenic role of tobacco varies depending on the tobacco product used, the way in which it is used, and its combination with other products. Tobacco smoke contains around 4,000 chemicals, out of which 60 of them have been found to be carcinogens, including nicotine, arsenic, methanol, and so on. And according to National Oral Cancer Registry, Northeastern region has been known to cause the highest incidence of cancer, leading to oral and stomach cancer, and the most common risk factors are tobacco. The following areas like the UP, Bihar, West Bengal, Madhya Pradesh and Gujarat and Rajasthan are also the causes for cancer, in which the etiology is mostly related to tobacco consumption. Another factor which we know is alcohol, and it acts as an irritant which increases the activation of pro-carcinogens and behaves like a solvent for entry of harmful carcinogens into the body cells. It may also suppress efficiency of DNA repair after exposure to nitrosamines. So despite advances in oral cancer therapy, the prognosis of oral and oropharyngeal cancer is still poor. Hence, emphasis should be made on its prevention. So there have been multiple studies which says that prompt and appropriate treatment helps in prevention of this deadly disease. So the prevention mostly focuses on early detection to reduce morbidity and mortality, and the opportunity to identify these pre-malignant disorders. The preventive strategies emphasis on tobacco cessation, limiting alcohol intake, regular dental checkups, in which early detection through routine oral examination remains pivotal role for improved prognosis and survival rates. A cost-based benefit analysis shows that outing resources into primary prevention would provide most beneficial returns. So the preventive measures is a multidisciplinary approach, and it is characterized into mainly three: prevention, that is primary, secondary and tertiary prevention. So primary prevention goals, there is increased public awareness regarding the risk factors, changing the behavior of the public, spread the devastating effects of the disease, and role of helpful screening techniques. So there are mainly three approaches. The first being the regulatory approach, in which the support and aids from the government is needed, which helps in cessation of the habit. There have been laws like Federal Cigarette Labeling and Advertising Act in 1965, which says that print warnings on the cigarette packaging. Other acts like National Cancer Control Program by Ministry of Family and Health and Family Welfare in 1975, and the Cigarettes and Other Tobacco Products Act, in which prohibition of advertisement and regulation of trade and commerce, production, supply and distribution was given in 2003 in India. Next approach is the service approach. The active search for disease among apparently healthy people is fundamental aspect of prevention, and this mainly encompasses the screening. The third and the most important approach is the educational approach, by which the public is made aware about the ill effects of the habits, which can be done using personal communication, newspaper articles, radio programs, short films, folk art, and also by posters. Next comes the secondary prevention, which aims at early detection of cancer, prompt treatment, and thus helping in cancer control. The third is the tertiary prevention, which aims at the terminal stages. Pain control and palliative care are the major strategies for tertiary prevention. So the important habits to be practiced to prevent oral cancer includes: eat more fresh vegetables and fruits, improve oral hygiene, quit smoking, conduct self-examination, exercise regularly, avoid drinking, stop tobacco use, and avoid prolonged exposure into direct sunlight. So as a healthcare practitioner, it is our job to conduct programs like de-addiction and cessation programs for tobacco, alcohol, and areca nut cessation, which helps in making the public aware. Also, to enhance the intake of fresh fruits and vegetables and reduction in processed fruit. And also the product and the patients and the public should be made aware about the availability of vaccine and the ill effects of late drinking and second-hand or passive smoking. The important thing is here the tobacco cessation, which mainly involves around the 5 ways. The first being ask, where the patients are asked about their habit and their statuses are recorded. Second is assessing, where the willingness of the patients are assessed. And third is advising, where the patients are advised about which should be clear, strong, and in a personalized manner. Next is to assist the patient in formulating a tobacco cessation plan and then to arrange follow-ups in each and every visit. While advising a patient, 5 R's should be considered, in which includes relevance, the relevance of the habit quitting, risk involves when patient does not quit, the rewards, benefit of quitting the habit, roadblocks which are encountered during the cessation program, and repetition, in which the benefits and ill effects are repeated at every visit. There are certain drugs which have been approved by FDA, which are nicotine replacement therapy, categorized as nicotine replacement therapy, which is available as patches, gums, sprays, and other drugs like bupropion, which can be used in helping the patient to stop the habit. And another mode of this can be through heavy taxation on tobacco products, which can play a key role in reducing its consumption, especially in middle and low income countries. So primary prevention in day-to-day clinical practice can be done by absence of ashtray and any book of advertisement on uses of tobacco product, routine questionnaires about the use of tobacco, complimenting the patient who stop the habit, encouraging the tobacco cessation, display of educational material, and regular follow-up for examination of precancerous lesions. Important terms here comes chemoprevention, which refers to the administration of an agent to prevent a cancer from occurring. These can be a drug or a natural product. So the characteristics of these agents should be that it is easy to administer, little or no toxicity from the drug, affordable, no long-term adverse side effect, and can be administered only for a short time. So the various agents are, first one being the beta-carotene, which is a precursor of vitamin A, and studies have shown that lower level of beta-carotene can lead to cancer. The mechanism of action of beta-carotene is through its antioxidant mechanism by inhibition of free radical. And it is usually present in green leafy vegetables and orange fruits and vegetables. All can be available as tablet form. Next is the retinoids, which act through the induction of differentiation and can inhibit proliferation as well as program cell death. Next being the N-acetylcysteine, which is also an antioxidant and free radical scavenger. NSAIDs can also be given, which have been shown in animal models that it can help in inhibitors of proliferation. Vitamin E, which is commonly available in the nuts like walnut, almonds, hazelnut, has showed an inverse relationship of its level with oral cancer prevalence. Mechanism of action of this is through its antioxidant properties. Interferons along with retinoids have also shown anti-tumor effects. Melatonin, by many studies, it has been shown that it causes antioxidant activity and produces oncostatic effects by increased secretion of cytokines, increase in the number of T and B lymphocytes, and natural killer cell activity also increases by melatonin, thus causing an oncostatic effect. Tea, which is commonly available, it has shown to inhibit carcinogenesis of oral cavity, lung, and esophagus cancer by inducing apoptosis and reducing cell proliferation. The polyphenol present in it helps in targeting the potential cells. And according to the animal model, 0.6% of green tea has shown to lower the detectable tumors by almost 35% and tumor volume by almost 57%. It shows antioxidant or pro-oxidant activity. Curcumin, which is usually found in the turmeric, it inhibits carcinogen-induced tumorigenesis and is also non-toxic and is easily available. Chiasmatic gum extract, which is a plant-based resin, has shown to inhibit cell proliferation and have its antioxidant properties. Tulsi, it acts as a cytotoxic agent against various cancer via apoptosis mechanism, and it has been shown through studies that 20 microgram per ml of aqueous extract of light leaves and 10 of that of dark leaves was found to be effective dose in reducing the cancer occurrence. So to summarize, various chemoprotective agents like retinoids, beta-carotene, vitamin E, interferons, they all act mostly by their apoptosis and antioxidant property, thus preventing the occurrence of cancer. Research is an ever-evolving field. So there have been researches in which they have shown that DNA changes, new modalities like DNA changes can also be used to prevent oral cancer. So DNA changes, these tests can be used to detect the gene changes which may allow oral and oropharyngeal tumors to be found early. One of the changes often found in DNA of oral cancer is the mutation of TP53 gene, which can lead to increased growth of abnormal cells and formation of cancer. These tests may also be used to find better cancer cells that may have been left behind after the tumor is removed, and also to determine which tumors are most likely to respond to surgery or radiation therapy. Another modality is vaccine. So as we know, vaccines are available for HPV infection to prevent the cervical cancer. So they have been found that it can have an added benefit of preventing some oral cancer as well. Gene therapies that interfere with the growth stimulating effect of certain HPVs are also being developed. Gene therapy add new genes to the cancer cells to make them more susceptible to being killed by certain drugs. So, to summarize the various modalities of prevention, they can be usage of screening techniques using various models like Visilide, Wellscope, or preventive agents, as I spoke, retinoids, beta-carotene, biomarkers, T constituents, antioxidants, and oral cancer screening tools. So oral cancer screening tool, this is also an important part of the prevention in which the patient is evaluated through a series of examinations. So first, the patient history is taken, which tells the extent and severity of the disease, and assessment is done about the duration, type, rate of progression of symptoms. It provides estimates of prognosis and aids in treatment selection. A thorough physical examination through careful inspection and palpation also plays a role, in which pathological changes are noted for any abnormality in texture and color, and assessment of nodal status is also noted. Patients' medical records also help in assessing the comorbidity. So one of the most important assessment, which is usually ignored by many, is the psychosocial assessment. Patients actively abusing alcohol should undergo detoxification to avoid withdrawal reaction during therapy. Nicotine withdrawal leads to anxiety, sleep disturbances, and headache. Appropriate pre-treatment counseling helps to encourage patients to participate actively in further treatment plan. Various radiographic examination can also be done, like CT or MRI, to detect cancer in early stages. Cytology also plays an important role here, where fine needle aspiration biopsy or cytology can be done, which saves time and is a rapid method, relatively non-invasive, and also can be used in oral cancer screening program. Another modality is molecular biology, where application of it will add up to refinement in oral cancer screening techniques. A new tumor antigen, A9/A6B4 integrin, has recently been shown to have prognostic value. Assays for mutation in P53 gene also have shown promise in cancer screening. So, when a patient comes to us, first assessment should be made, in which first history, risk factor assessment should be done, A comprehensive head and neck examination should be done, which tells us about whether the patient has normal examination or abnormal. If abnormal, the patient can be categorized into obvious clinical diagnosis, where the treatment is based on the diagnosis. A patient can be suspected of frank malignancy, where immediate referral should be made to the specialist. When the uncertain clinical diagnosis is made, a provisional or working diagnosis should be done, in which if no clear etiology is found, a clinical diagnosis of oral potentially malignant disorder should be made. If suspected traumatic or infectious etiology, the treatment is based on possible etiology. Whether it is resolving, then a patient should be kept on follow-up, or if it is persistent and progressive, then a clinical diagnosis of oral potentially malignant disorder is made, and the further patient is planned accordingly. So to conclude, oral cancer is increasing and the treatment costs associated with it are high. Despite advances in cancer treatment, the survival rates of patients suffering from head and neck cancer has not improved substantially. Thus, a multidimensional approach which focuses on patient awareness and education along with risk factor control, prevention and treatment is very essential and could be the hallmark to reduce the threat. So I would like to say that an ounce of prevention is worth a pound of cure. These are the references. Thank you.
थैंक यू डॉक्टर दीक्षा, वंडरफुल प्रेजेंटेशन।
Thank you, sir.
मुझे लगता है कि कुछ पॉइंट्स हैं जो डॉक्टर दुबे से भी मैंने डिस्कस किया है, हमें उनके बारे में थोड़ा कंसिडर हम कर सकते हैं। जैसे कि जैसे हम लोग रूटीन डेंटल ओपीडी में हम पेशेंट, क्योंकि हमारे पास, मैं मेडिकल कॉलेज से हूँ LLRM से, और हमारे पास जो जिस बैकग्राउंड के पेशेंट आते हैं जनरली वो कॉम्प्रोमाइज्ड इकोनॉमिक स्टेटस के आते हैं।
Yes.
तो हमें कई बार देखने को मिलता है, डॉक्टर विष्णु भी मेरे साथ हैं, कॉलेज से ही हैं, कि जो शार्प टूथ को पेशेंट इग्नोर करता है, कंटिन्यूस जो उससे ओरल कैविटी में जो इरिटेशन होता है, क्रोनिक इरिटेशन, और उससे एक नॉन हीलिंग अल्सर टाइप का फॉर्मेशन होता है, पेशेंट अनअवेयर होता है, दैट मे बी वन ऑफ द कॉज
Risk factor. Yes.
है ना। इट शुड बी प्रिवेंटेड बाय, वो डेंटिस्ट ही कर सकते हैं कि अर्ली उसको हम जो शार्प टूथ है उसकी उसको हम रिमूव कर दें। वन थिंग जो हमें रेगुलर मिलती है कि जैसे कि इल फिटिंग डेंचर्स होते हैं,
Yes, sir.
या कोई क्वेक्स जो डेंचर्स फैब्रिकेट कर देते हैं, वो रेगुलर इरिटेशंस करते हैं, या उनको जो उनकी जो फैब्रिकेशंस है वो एक तरह से माल प्रैक्टिस टाइप का होता है कि वो एक्रेलिक कोल्ड क्योर से फिक्स कर देते हैं। वहाँ पर भी मिलता है कई बार जब हम उसको रिमूव करते हैं तो हमें डाउट होता है कि ये डाउट होता है कि ये मैलिग्नेंट चेंजेस यहाँ आ रहे हैं, कि उसको बहुत लंबे समय से पेशेंट बियर कर रहा है। बाकी एक जैसे टोबैको से ही रिलेटेड है कि जो रूटीन प्रैक्टिस में, जैसे अब टोबैको क्विट्स का नहीं, अब जनरली पेशेंट अब या स्मोकिंग भी शायद उतना नहीं है, लेकिन ये गुटखा जो है, गुटखा वो रूटीन प्रैक्टिस में हमें देखने को मिल रहा है। लगता है कि जैसे हम पेशेंट का जैसे हिस्ट्री लेते हैं हम, कि जहाँ हमें डाउट होता है कि भाई ये मैलिग्नेंट तो नहीं है, तो उसमें हमें ऐसा लगता है कि गुटखा मेजर रीजन है। तो लगता है कि सोसाइटी लेवल पर एक सोशल प्लेटफॉर्म लेवल पर हमें गुटखे को डिस्करेज स्पेशली करना होगा, रादर कि हम टबैको को तो करेंगे, टबैको स्मोकिंग सभी के साथ, गुटखे को हमें, मुझे लगता है कि स्पेसिफाई करना होगा। क्यों डॉक्टर साहब, है ना, स्पेशली। अच्छा, और एक डॉक्टर साहब जो है क्या, अच्छा, एक हमें जो रूटीन हम वो डेंटिस्ट के लिए है कि अगर हमें डाउट कहीं हो रहा है पेशेंट को कि या तो प्री मैलिग्नेंट है या वो कन्वर्टेड होने वाला है, तो उस समय हम एज अर्ली एज पॉसिबल जो है वो हम ऑन्कोलॉजिस्ट को रेफर करें पेशेंट। क्योंकि जनरली मैंने प्रैक्टिस में जो मेरा ऑब्जर्वेशन देखा कि हम इनिशियली विटामिन, एंटीऑक्सीडेंट, लाइकोपीन, इस पर पेशेंट को हम जो है लंबे समय के लिए कहते हैं कि देखते वेट एंड वॉच। कई बार देखने में आया है कि कंडीशन उल्टी एग्रेवेट हो जाती है, और मुझे नहीं लगता कि बाकी तो देखिए जो एक्सपर्ट्स हैं वो बताएंगे कि कोई बहुत ज़्यादा इफेक्टिव रोल इन सब का जो वो है नहीं। अगर वंस द लीजन इज प्री मैलिग्नेंट, कोई बहुत ज़्यादा उसका इफेक्टिव रोल है नहीं। कहते कि हम अर्ली, अगर हमें डाउट कहीं भी हो रहा है, इट इज़ बेटर कि हम उसको अर्ली जो है वो हम ऑन्कोलॉजिस्ट को रेफर कर दें। वो बेटर एडवाइस कर सकते हैं कि हम इस पेशेंट को होल्ड ना करें, मुझे ऐसा लगता है कि डेंटिस्ट को होल्ड नहीं करना चाहिए पेशेंट, कि हम अर्ली उसको रेफर करें। ठीक है, थैंक यू।
Thank you, Dr. Tiksha, for the presentation. Early detection and the prevention you have covered very briefly. Thank you so much. Any question from the audience? Thank you.
Thank you, Dr. Titiksha Jain, for generously sharing your knowledge and experiences with us. Now, I would like to request Dr. Sumit Shah to come forward and present the token of appreciation to our esteemed speaker, Dr. Titiksha Jain. Thank you, sir. Now let's take a 15-minute tea break. After that, we may resume.
further to the next session, I would like to call upon stage Dr. S.P. Sondi, Professor, Department of Medicine, Subharti Medical College, who would present on the topic Symptoms, Signs and Tests, the general practitioner's comprehensive approach towards cancer diagnosis. This session will be chaired by Dr. Saurabh Singhal, Dr. Sumit Kanjar, Dr. Shefali Nandwani, and Dr. Snehalata Verma. I'd like to welcome all of you on the stage.
Thank you. Can I have my slides, please? Who's managing the slides? So can I change the slides from this pointer? Okay, right. So I'm honored to be here, and actually, thank you very much, Saurabh, for calling me to an oncology conference. This is my first talk in an oncology conference. You may wonder what I'm doing here, a physician, a general care physician. I'm also wondering what I'm doing here. So, thank you very much. This is my first
Welcome, sir.
First talk in oncology conference. And again, because I was told to choose my own topic, I chose the role of primary care physician in oncology. And I'll just have a couple of slides to show you what is the current scenario. And just before this talk, in one of the talks, we were talking about the exponential growth of oncology in hospitals, and it's not without reason. Now, if we see, the cancers account for a large number of deaths globally, about 1 crore. India is at number 3. India is big, so India is at number 3, number 2, number 1 everywhere, not only economy, but diseases. Unlike developed countries, that's where the difference is. Unlike developed countries where 70% cancers are diagnosed early, in India, 70% cancers are diagnosed late. And of those 30% who are diagnosed early, most of them belong to urban areas. So that means in rural areas, there is a huge, big gap how to diagnose. India needs about 572 newly comprehensive care centers in cancer. Current ratio of oncologists is 1 in 2,000 population, and required rate is about 1 in 100. So we are sure that oncologists alone will not be able to tackle this huge, big problem which is coming. Now, if you look at this, even those specialized centers are localized in about 15, the pointer is not working, but in these top 15 states account for major share of cancer care hospital. So the rest of the states do not have cancer care hospitals. So there is a huge scope for people like Dr. Sandeep, who's growing exponentially. And of course, this is a very recent article which says why cancer is the new cardiology for all the hospital chains. The cancer is as attractive as cardiology. What are the future projections? What is going to happen in future? Well, there is going to be a rising demand. Research predict that there will be insufficient oncologists to meet this demand. And it is estimated that cancer incidence will increase by about 20 to 50% over the next 20 years, reflecting in part aging, obesity, and other factors. We all know that age is not just a number. Most of the tumor, 90%, are diagnosed over the age of 50, and most cancer cases occur over the age of 60, and we know that our population is aging. Even in India, our population is gradually increasing, and so we will have more and more cancers happening. The problem is that when we age, whatever cells are dividing, many of those cells do not divide properly and they have mutations. And from these mutations occur cancer. And so the question is not why the cancer is increasing so rapidly, but why every one of us do not have cancer. Because ideally, with that kind of 30 trillion cells replicating, all of us should have cancer. Another factor which is causing this exponential rise in cancer, we don't realize, is the obesity. Obesity is rising. It will rise further, and we don't realize that obesity increases the occurrence of breast cancer, gallbladder cancer, ovarian cancer, colon cancer, and so on and so forth. And obesity is another cardiology for physicians, because there is a huge amount of money in treating obesity right now. There are good Ozempic and other drugs coming out. They'll soon be available in India, and it's a multi-billion-dollar disease to have. In addition to the major contributor to cancer complexity is the environment which we live. The environment is changing very rapidly. It has already changed. And so to summarize, because of aging and other things, there are mutations, and there is some genetic background, and then there are known or suspected environmental promoters like air pollution, water contaminant, pesticides, chemicals, e-cigarettes, microplastics. There was a recent article in NEJM which showed that microplastic is present within the coronary arteries, and it increases the ischemic heart disease. So microplastic is not just in sea, but it is in our blood now. And that is also causing or adding to the cancer. Of course, smoking, infections, aging, obesity, stress, sleep deprivation. 6 to 7 hours sleep is extremely important. But at the same time, there is a ray of hope. We are in the middle of exponential increase in the knowledge of cancer biology and genetics, so much so that sometimes these reports come, about 20-page report about a particular cancer, and physicians don't know ABCD about it. He says, I don't know anything about it. About 1,000 genes have been identified that are altered in tumors, either genetically or by mutation. And so we will hear about genes in the coming time. So when we have seen all this, we are going to age, we are going to become more obese. The point is that there will be more and more cancer cases. So how will we tackle, how will we improve screening, diagnosis, treatment, etc., etc.? Well, most of the time, right now, after the diagnosis, the whole patient is given over to the tertiary hospital, to the oncologist. And, most of the time, the primary care physician washes his hands off him, and he says, now you are with the oncologist and do whatever you want to do. And where there is already a shortage. So there is not only a workforce shortage, there is cost concern, there is access issue. A person living in the remote village has to go to Delhi for treatment, which is not good. Where do we fit in? Primary care physician, where do we fit in? So let's start thinking about that. And I think you cardiologists have to change a little bit and involve us much more in future than otherwise for a better patient care in oncology. I hope Sandeep is listening. So our role in early diagnosis, that's amazingly very, very, very important, because early diagnosis changes the whole scenario in cancer treatment. And we know that 70% patients in India of cancer, they are not diagnosed early. So you got to involve, primary care physicians in making an early diagnosis, because we get the bunch of these people. We get these people in tons. Many of us, I don't see, but many of us see about 80 to 100 patients a day. And, if you multiply that, that becomes a huge number. So we can actually pick up more cancer than any one of us. And so screening of asymptomatic individuals have to be done regularly To give you an example, if the screening protocol says that women over the age of 50 should have mammograms every 2 years, well, are we getting it done or not? Are we even aware of the protocols which are there? And then, of course, there are some symptomatic patients who should be diagnosed fast. I mean, they already have a symptom. So it depends on how do we approach a Bosniak 3 renal cyst. Do we interrogate that patient? Do we try to investigate that patient for renal cell carcinoma or not? All those things are there. So because we get the load of patients, we are the best people to pick up early cancer. But it is almost like we are busy, we see 100 patients in a day, we have no time to, think about other things, but we should have. Especially with now computerization of our patients, we can do it much more efficiently. How can we do that? There are some. One is audit and feedback. If we have everything, all data on computer, someone can analyze it for us, that how many, plus 50 ladies who came to us, how many of them were subjected to mammogram or not, and then give us a feedback, and then we will know how much, what we are doing. Right? Sometimes we do this feedback system for our diabetic patient. So many diabetic patients coming to us. What was their average A1C? If their average A1C was 8, 9, we know that we are not doing well. So this is one area where we have to, and of course, I think ultimately all our records have to be on computer. Then office system prompts. This I had the idea, I had the vision, but I could not implement it. I wanted the office system to be so agile, the computer, that it should send automatic SMS to my diabetic patient who have not done A1C in the last 6 months, who have not done fundoscopy in the last 1 year. I wanted that, but I'm an old man, and sometimes I give up when the things don't happen. But for young people, this is a thought, that office system prompts, and now with more and more AI coming, this will be very easy. This will not be difficult. Separate clinic for screening, I think that's a wonderful idea, especially for a Subharti like that. You should have a separate clinic for screening, that anybody who wants to get screened for cancer comes there, and you have protocol-driven people sitting there, and that doesn't have to be an oncologist. It is a job of a physician, primary care physician. So this is a good idea. Financial incentive, they are given in NHS. I was talking to one of my colleagues in NHS, National Health Scheme, and he says, I get my money depending on how many smokers I prompted them to quit smoking. So if my 100 patients have quit smoking, I get more money. So I don't know how to do it in India, but yes, it is a possible. Nothing works like money, so it's a good idea. But this is the most important thing. Why we don't do a particular thing? Why don't we screen properly? Because we are not aware of screening protocol. I think this is extremely important. And even if we have to come to clearing examination every 5 years or so, it is a must that we should. Primary care physicians should know what are the screening protocols, and they have to be taught, and maybe every 5 years or so. Like, to give you an example, one of the most misused drug is proton pump inhibitor, and we all know that absolute indication of PPI are just these 4: dyspepsia, treatment of H. pylori, peptic ulcer, GERD, and NSAID. There is no other absolute indication of giving PPI. And when you give PPI, it delays the diagnosis of gastric carcinoma. There is a written recommendation that do not prescribe PPI before upper GI and endoscopy in patient over 45 who are symptomatic for early malignancy. So I gave this just example. This is just one of the examples that we have to be aware of what are the protocol, and we should be protocol driven. At least in teaching hospital, we have to be protocol driven. Unfortunately, I don't see that. So one is screening, that we have diagnosed the patient. Now at the time of diagnosis, what is our job? I think most of us are doing this job. We talk to the patient, explain him the prognosis, give him a little hopeful scenario and tell him you have to go to an oncologist, and then we can fix up their references and so on and so forth, and then update the vaccine, etc., etc. These are what a primary care physician can do at the time of diagnosis. During the treatment, of course, the treatment has gone beyond our limits. I mean, about 30 years back, I used to treat some cancers on my own, but gone are the days, because cancer treatment has improved dramatically, has changed over the time, and we have no business to treat cancer, but we have to give support to the patient and create a link between the treating oncologist and the patient. Many times the patient has many questions which he cannot ask you, and then we are the people who ask those questions and convey the answers to the patient. And of course, we have to manage diabetes, and I may tell oncologists that we manage diabetes and blood pressure much better than you. So please, involve us, right? So that's what I mean. And of course, many a times the patient comes to me and he says, I am getting chemotherapy done in Delhi, and I've got fever. Now what should I do? I mean, this is a very tricky question, because fever in oncology can be varied. What's your count and other things. So I, as a physician, don't know many of the side effects of the chemo agent being given. And many times I have to tell him, which chemos are you taking? Leave it on me. I'll actually go back to books and see and tell you tomorrow. And then I'll be... So a lot of these situations we have to talk. And so I must say that oncologists should be in almost constant touch with the treating physician most of the time. Follow-up, well, we know that when the patient has been treated and is in follow-up, well, there could be recurrences. So what is the screening procedure after treatment, and his physical aspect, his psychosocial aspect, health condition, vaccination programs, all those have to be done by a primary care physician. This is extremely important. At the end of the life care, when the oncology patient is dying, he becomes he is dumped, and nobody wants to see him, oncologists say, no, I've done my best, I'm done, so you have to die now, you go home and die. But what does he do? I mean, how does he manage his pain? How does he manage his incontinence? How does he manage other things? So I think this is the time when, if we cannot give patients a life, we have to give them a dignified exit. We have to give them a dignified death. And I remember one of the articles written by a cancer surgeon who was dying. A surgeon himself had cancer and was dying, and he wrote in a newspaper, he says, cancer is not a bad thing to die with. He said, most of the cancer give you about 6 months to 1 year, maybe 2 years. And you can plan your exit. You can plan your finances. You can talk to your wife. You can shift the account. You can shift your legal, requirement. He says, you only require good painkillers, and you only require good friends, and then you can die. It's much better to die of cancer than of a sudden cardiac arrest, where you just exit the world without any preparation. So that was an interesting, take on cancer. So end of the life, of course, is much better with a primary care physician than with an oncologist. The patient has been there with us for last 20 years, 25 years. There are families in whom I have treated 4 generations. So 4 generations faith is a huge faith. And, the problem is that we also dump the patient. We also say that I can't do anything. And, we don't do home visits and other things. And so, there is a scope of this. And I know that in Mumbai at least, and at many other places, there are some voluntary organization where people who are end of the life, they go there and they're taken care of, in all aspects. We require... so if there is an oncology-led care, if you look at that, oncology-led is more expensive as far as cost is concerned, and if you involve a primary care physician, the cost probably will come down. And of course, the problem with us is this, that many of us are totally unwilling to take on oncology patient, cancer patient. We say, oh, we are done. I don't know anything about it. You go to the oncologist. We don't want to do it because our knowledge is very limited. We don't know many of the drugs being used and other things. And secondly, we have a workforce limitation. We are already inundated with the patient. And so we don't want to give these patients who cannot improve more time. So this was a good, one slide which talks about the barriers to primary care physician delivery of oncology care. And if you look into that from the top, lack of expertise, limited formal knowledge, desire for formal training is about 60%. 60% of physicians think that we can take on oncology patients along with you, but we have to have more knowledge. And then, of course, there is time and workload pressure. About 36 to 87% feel that we don't have time. Then there is not enough budget. Then there are not enough resources. And in the end, about 84% of primary care physicians feel that we will go into medical legal issues if we start looking after oncology patient, even when the oncologist is also treating. So these are the issues. I think we have to look after these issues. So last few slides in a nutshell, I feel that a primary care physician must be involved right from stage one, from prevention. Prevention, we can do a lot. Every patient who comes to us, if we just ask them a question, do you smoke, do you drink, do you walk? And if the answer is no, I mean, I don't walk, but I drink, I smoke, we can tell them that you're doing the wrong thing. Then we can do screening. Then, of course, in diagnosis, treatment, survivor, end of the life care, in all these steps, we can be hand in hand with the oncologist, and that will improve not only the quality of care, but also at much lesser cost. What is the future? Well, future is very exciting, and I can predict anything but future. And I was very interested in seeing these last two slides. Now, this slide says the future is that, one of the future is that the whole population will be stratified in low risk, medium risk, and high risk, and then they will undergo the test. Or they will have a multi-cancer blood test for all patients over the age of 55. And these multi-cancer tests are like liquid biopsy. That means we want to kind of pick up the tumor parts or the tumor metabolic parts or something in the blood. And this is going to be a reality in another 5 to 10 years, that you can go and just get all the tests. Now, of course, the other is that you can wear certain things which will warn of cancer. There is already a bra which is being made, which uses microwave, which will tell the patient that you are about to get a cancer or something like that. And then, of course, these things, of course, you know much better than me. Nano contrast agents are coming. Wearable sensors are coming. Smart tattoos are there, which will light up if they see or detect in your interstitial fluid some cancer, parts. So all this is future, and this is not going to happen in 100 years. This is going to happen in 10 years. Mind my word. So, thank you. Thank you very much.
Definitely a very good talk, sir. Sorry, sir. Actually, I forgot to introduce Dr. Sondi, sir, before the presentation. Sondi, sir, was my guide. He has taught me everything. What I am today is because of him. So, he needs no introduction. He is a very esteemed figure for the population of Meerut. He is a very good physician in Meerut. He is guest faculty in medicine department in Subharti. And the talk has said it all, I think. Any questions from the audience, if any? Yeah.
Last case he mentioned about early detecting cancer from the blood is already available in Bombay and would be available in America next month in Delhi.
Sir, we would like to collaborate with the Department of Medicine and set up a screening clinic at Subharti, both in the hospital, main hospital campus, as well as in some rural outreach areas, like, Kajuri and other villages, where they have outreach villages. And we would like to involve your team, the Department of Medicine, for training how to do screening and how to prevent.
Good.
Thank you very much.
I think I have only one more request to all the oncologists who are sitting here. If you see any physician's patient and you are kind of discharging that patient, please send a small note to the physician. Please, please, please send a small note to us, just telling us what to do in the days to come. Don't give it to the patient. Send it directly to us. And it's not a big deal, I'm asking. Your secretary can do it. Somebody else can do it. And this will go a long way in kind of a collaboration. I know what I am to look for in this patient in the next 6 months or 1 year or something. Please, Sandeep, I expect it from you, at least. So if you don't do it, I'll complain.
Sir, what you are saying, sir, is a routine in NHS in Britain.
Thank
So we as residents
Yeah,
and surgeons
yeah, I agree.
used to send a letter to GP. Dear Dr. Williams, thank you for sending this patient. She had breast cancer, we have operated this. Now please continue giving tamoxifen, control blood pressure, everything, and send her for follow-up. Arrange mammogram at your end and send her if there is a problem. So this is a routine.
Thank you. Yeah.
Sir, when I presented my presentation, and when I said who should be the part of, who should be in the team, who should be in the team to manage cancer patient, so I wrote a line that the treating physician should be part of the entire continuous cancer care. So I fully believe in what you are saying, and what you are saying that yes, I'll remember it, I'll follow it, it should be followed. But problem is, most of the physicians, they don't take interest, like once they send the patients. And after like 1 or 2 times when you feel कि no, आप कर लो जो करना है ना डॉक्टर साहब आपके पास भेज दिया. This is what we hear.
I know.
So then you become reluctant to tell them. But definitely we'll try to find out a model, we'll try to find out a tool also, which gives continuous information to physicians. It's a very excellent, informative, educational talk, and I think a very guiding talk. Thank you, sir.
Thank you, Sondi sir, for the very crisp and to the point talk, and that is the need of the hour. And you are rightly said that it's a high time to collaborate the physician and the oncologist team. If we really want to treat the cancer patient and to eradicate or to lower the number of cancer patients, to relieve the pain of the suffering, the needy patient. And that's a good idea, and we hope that we all will do it, especially the risk reduction and the preventive aspects, that the utmost need to strictly follow this. Thank you for the Subharti team for organizing this oncologist conference, and best wishes to all of you. Thank you all.
Thank you, Dr. Sondi. This was such an exceptional presentation, which was delivered with clarity and enthusiasm. Your words were both enlightening and inspiring. Ladies and gentlemen, now I would like to invite Dr. Anjali Khare to come forward on the stage and present a token of appreciation to our esteemed speaker, Dr. Sondi, and to our chairpersons.
I would now request Dr. Dinesh Pendhelkar, Director, Sarvodaya Cancer Institute, to enlighten us on the topic Establishing a Successful Bone Marrow Transplant Unit, Strategies and its Implementation. The session would be chaired by Dr. Anurag Srivastav, Dr. Mukesh Maheshwari, Dr. Sanjay Pandey, Dr. Vishal Saxena, and Dr. Arun Kumar Verma.
किसी का फोन छूट गया है यहाँ पे प्रीवियस सेशन का किसी का फोन छूट गया है फिर मैडम का फोन
Thank you very much for giving me this opportunity. I am really honored to be here to present to you something about bone marrow transplantation. Yes, I know majority of you may not be directly involved with this topic, and for you it really may look something from the moon, but believe it, it's one of the most important topics in oncology today. You cannot proceed with oncology care if you do not know this and if you do not have this. Because you know the latest treatments which are coming in oncology today, from the news you know, is CAR T cells. So for every cancer we are trying to develop a system to fight its own body. So we are trying to teach T cells to kill cancer. This can only happen if you have a unit of bone marrow transplant, if you know how to do transplant, then and then only you will be able to really use this new technology. Lymphoma, leukemia, myeloma, the treatment is already approved. It's likely to come in for prostate cancer and other cancers. So I personally feel every institution should start thinking of this right from now, and I'm really happy that this hospital, Subharti, has thought about this and given me this topic. So it's really a very interesting story why I'm speaking this. If you read this, it's a seminar on recent trends in bone marrow transfusion. Even we were reluctant to use a topic called transplant, and the date is October 1986. So this is Vigyan Bhavan, Delhi, Ministry of Defense and Ministry of Health with AIMS Delhi. This meeting was organized, and I spoke there. My presentation was establishment of bone marrow transplant unit. So in 1986, also I had the same topic. So I'm really happy to come back to my topic literally after 40 years. It's still important even after 40 years. So this is later 1986. Why I'm showing you this? Because Ministry of Defense came and said, if there is a nuclear warfare, how will we save the people, say in Delhi? So you have to create, and the treatment of nuclear warfare is only transplant. So Ministry of Defense came with this idea. Myself and Dr. Shyam Agarwal, we went to Germany just to study how it is. Though I'm in transplant, actually I'm in transplant field from 1981. So we studied this, and then we gave a presentation here in this meeting, and we designed a transplant unit for IRCH AIMS Delhi. So this is how the history of transplant is. I did a transplant in a rural setup in Indore, 1997. So I really know. So from 86, it took me 13 years, 11, 12 years to do a first transplant in small setup in Indore. It's a tough journey. So I wish you start the journey today so that now you can actually make it faster than what actually I did in my life. You see the numbers? If you see 2021, 12,000 autologous transplants and beyond 8,000 allogenic transplants in America. So 20,000 transplants in 1 year with a population of 33 crore people. So with a population of 150 crore people, we actually expect this to be at least 5 times. So we should be having at least 100,000 transplants in a year. And how much are we doing? 2,000. So there is a huge scope for all of us. You may say incidence of cancer in India is 4 times less than in America. But transplant is not only cancer, general hematology. If you just take sickle cell patients, in America I think there are about 70,000, in India there are 300,000 sickle patients. Thalassemia, there is no town in this country where you do not have thalassemia patients, at least every district transfusing 25 to 30 children every month, every district of this country. So it's a big need, and our numbers, we could actually reach these numbers if we have a facility. Definitely there are multiple ways of doing transplant. We can use a relative donor. So with time, with 2 children in a family, sometimes 1 child in a family, it is very likely that we will have a matched related donor. We are unlikely to have. So majority of our transplants are now likely to be, the green line if you see is expanding. So green line is haplo-identical transplants. Mother, father, or a brother, sister who is not a match. This is the biggest number in 22. Unfortunately, we don't have donors. Another small thing is cord blood we discussed yesterday. That could be one of the good options for India because we really have large number of deliveries. So, but if we really seriously think, cord blood could be also a good option for this country. So haplo-identical transplant is future. So whenever you create a unit, please think from haplo point of view. All your team should be groomed up for haplotransplant. Majority is, as you said, 23% even. So like haplotransplants in America, it's grown to literally every 4 transplant. America had a very good donor registry. More than literally 1 million people are listed in donor registry. The European community is a very close community. It's very easy to find a match. In India, no, we are all different. We got very small groups, very small sects, very difficult to find donors in these sects. So 23% is haplo-identical. So my plea is, let's get trained for haplo-identical. So what do you really need to create a system of transplant? Believe it, it's not difficult. Today, the operation theaters, I know what your hospital has, is actually a room better than a transplant room. So I don't think today we have to think how to create a room. It's really easy. So we really need a physical infrastructure which is just clean. By clean, I mean we need a infrastructure with HEPA filter. You are all OTs today are with HEPA filter. So we don't have to learn now or even don't have to teach each other. But the only thing what is required is my humble request, if you create a room or a facility in your hospital, keep the air conditioning system of this area separate from the whole building. Because it's best to have 100% fresh air in the air conditioning and not a recirculated air. So the most important thing for any organization coming up with a transplant unit, an air conditioning should be separate with 100% fresh air. If just you do that, majority of the issues are solved if there is no recirculation. Creating positive pressure is easy. You have to really choose a place where you can have not one air conditioner, but an air handling unit and a pressure unit and all that. So create maybe top of the floor is ideal for such areas. Transplant unit should be actually top of the floor, so you have a whole top floor available so that you can put multiple units there. Team. You definitely need a team, but today, believe it, team is not difficult because you have a medical oncologist who is actually trained, and then I need a backup of my radiation team for doing TBI or TLI or something like that. So a team is important, but like this institution, you already have a backup of Department of Medicine. So you already have a big backup. You have a lab, you have a medical department backup, you have a surgery department backup, you have a micro backup. So creating a team is absolutely not difficult. You should just have a vision and a mission that I want to do it. Unfortunately, investigation pathway is a tough challenge in transplantology. Still, we have to outsource the samples, but my plea is it is better to outsource than do it yourself. For example, if you have to do a CMV titer or a viral titer, it's better that a central laboratory does it, because then a quality check would be better. If you start doing in small labs yourself, just one sample in a month, you cannot contain the quality. So it's better that we actually use central facilities, outsource facilities. Like there is some investigation in transplantology called DSA, donor-specific antibodies. It's really a tough test. It's done by NGS, and I really wish central agency does it than anybody else. But today the courier system is so good that you can actually outsource the sample and get it done. So for these specialized tests, I would request you to count on some central agency, some central lab, maybe private lab, whatever you decide, but not to develop them locally, because you will not have those many samples and you cannot maintain the cost and the quality. Medication backup is a must for a transplant unit. Please do not count on when required we'll purchase it. No, it should be there in-house all the time. Especially drugs like ATG, cyclosporin, methotrexate, cyclophosphamide, busulfan, all these drugs should be in-house. And antibiotic backup and antifungal backup is must. There should be no cutting short on the use of antibiotics. So whatever best available as per your medical indication, it should be available in-house, and we should not wait for the last day to buy them. Especially injectable antifungals, injectable antibiotics. There is still challenge in the country with antiviral drugs. They are still not available, and it's really very difficult to treat existing CMV infection. So something, probably with time, we will learn how to do that. The process of transplant today can be basically divided into five parts. PTIS is a pre-transplant immunosuppression. Extremely important, especially in sickle cell anemia and thalassemia. And believe it, if you start transplanting, you will have major number of these patients, because there is a demand. Every town has at least 25 children with thalassemia. We can actually start doing them. So if we do thalassemia and benign diseases, pre-transplant immunosuppression is very, very important process. Conditioning, fortunately, majority of the drugs are produced in India today. In fact, India is supplying 50 to 70% of the transplantation drugs to the world manufactured in India. So we are very good, the costing is good, there is not a big deal. As far as infusion of the stem cell is concerned, storage facility, my advice will be, let us not create a storage facility on day one, use an outsourced service, but once you become regular, you can create storage of your own, you can start storing yourself the stem cell. Post-transplant cyclophosphamide has become a cornerstone. So what we want to do is, we still further want to suppress the immunity, and PTCY is helped us in doing haploidentical transplants. So if the number of haploidentical transplant is increased today, it's just because there is a use of PTCY, and we know how to start using. You started using post-transplant cyclophosphamide. This is the reason that haploidenticals are increasing, because we are seeing less and less side effects of even a match which is not a complete we can use for the transplant. So we can use a match which is not a full match, and we can still do the transplant, thanks to this technology of PTCY. GVHD prophylaxis has become very, very easy in this country now. There was a time where I remember in old days in AIMS, 85, 87, even getting cyclosporin was very difficult. Today, cyclosporin, sacrolimus, tacrolimus, everything is available. Besides that, the levels are available, which are really very cheap. So you can literally get a sacrolimus, tacrolimus level in 2,000 rupees. So things have really become very easy for us to transplant, and this would be the new methodology which all of us should use. So this is a very interesting graph. If you see this, the orange one, it says MDS MPN, myelodysplastic syndrome. Myelodysplastic syndrome is a disease of the age. Dr. Sondhi has just said, we are aging. So more and more people now would get myelodysplastic syndrome. You will get more and more adult people, 60 years, 70 years, I'm sure we are not investigating them now, but if we start really investigating low hemoglobin at 70 years of age, our number will be huge. And we are really aging very fast. The society is aging very fast. So this is the number. You can see in America also, it's literally number 2 for the transplant. In haplotransplant, number 2 is myelodysplastic syndrome. With our aging population and with 1.5 billion population, this number could be huge. So I really want all of you to really start seriously thinking about transplant units. It's worth a unit. So graft source, as I said, majority of the time is peripheral blood. So there was a time when bone marrow was used. There was a time when bone marrow was a prime. If you see the early days, it was bone marrow was really 50% of the stem cell source. Today, peripheral blood is a stem cell source, which is very easy. I'm sure you already have a cell separator, and taking stem cells out is not difficult at all. You will be able to do it. So as I said, GVHD prophylaxis, whenever we do haploidentical, and believe it, all of us will have to learn only haploidentical, because there is no other way. It's very unlikely that you will get a full match. So we have to learn the technology of post-transplant cyclophosphamide using methotrexate and using ATG. ATG does increase the cost, but this cost would come down with time. So today, haploidentical is extremely important for us. So if we really see the conditioning regimens, what we are using, these drugs like busulfan, cyclophosphamide, busulfan, fludarabine, everything is manufactured in India, very cheap. So today, cost of transplant has really come down. We can do an haploidentical transplant in just 20 lakh rupees, 20 plus minus 2, which is very cheap. In America, it starts with $250,000 US. We are able to do it, reduce the cost, because our admission cost is very low, our professional cost is very low, our drug cost is very low. And if your institution starts doing transplant, I assure you, you will be able to do it even cheaper, because if you are doing, say, 3 transplants in a month, you have such a big hospital that if you get donation of antibiotics, antifungal from your main department, you can do the transplant free, because the meropenem or lipo-M4, it can actually come from Department of Medicine for one patient free of cost. So you can actually reduce the whole cost. The cost of the room is in your control, again a very low cost. So basically what you will be paying will be only for outsourced investigations and few drugs which routinely are not used in a hospital. So actually you can reduce the cost literally below 10 lakh for a haploidentical transplant. We are able to do auto transplant when something patients ask us. We're actually able to do it. We've done it in even 3.5 lakh rupees. So it's not transplant. It's a decision to do it is more important. So this is what I started my lecture with. So number of CAR T cells done in 2022 is much more than this. In 2022, it was a huge number. I think it's beyond 10,000. So CAR T cell is the treatment of the day. Every lymphoma, leukemia patient, myeloma patient today will go for CAR T cell treatment. It's like next line of treatment. So you should be geared up for next line of treatment. India, we have already, 2 companies have already introduced CAR T cells. One at a cost of 70-80 lakh rupees, one at a cost of 40-8 lakh rupees. Plus, so CAR T cell, what is a CAR T cell? You take out from human body, from the patient, T cells out, teach them how to detect an antigen which is sitting on a lymphoma cell, reintroduce these CAR T cells into the body, and the CAR T cells so introduced will go inside the body and they will eat out the lymphoma cells. So definitely CAR T cell is the future. So CAR T cell definitely is the future. So one company is 70 lakhs, another company 42 lakhs. But this procedure involves autologous bone marrow transplantation. So CAR T cells can only be done if you have transplant capacity. So unless you do a transplant capacity, you will not be able to do CAR T cells. And today, if you want something best in your life as an oncologist, I want to do CAR T cells. I cannot be away from that. So if some oncologist joins you, the first thing you should ask him is, are you willing to do CAR T? If he says no, don't accept him. There are oncologists who want to do only solid tumors. My humble request to this organization at least, take an oncologist who is willing to do hemato-oncology, CAR T cells and solid tumors. That is the future. Just one solid tumor is not the future. We can have them. If you got multiple, yes, then you can choose. But you have to choose one, choose with an intention to do CAR T cells. So auto transplant 10 lakhs and the drug 42, it comes to 50 to 55 lakhs of treatment. There are two more companies which one trial we will be starting next month on CAR T cell in Sarvodaya Hospital, Faridabad. And one myeloma CAR T cell again will be starting after 3 months. So there are another 3 companies starting CAR T trials. So within next 1 year, you will have enough of companies with CAR T cells. So if you have a patient who is a candidate for CAR T cells, there are at least 3 trials now running in the country. So my request to you will be, before sending a patient for CAR T treatment, inquire if the patient is fit for inclusion in the trial, because then he will get it free of cost. So CAR T trials are happening, you should be aware. Again, as of today, CAR T indications are myeloma, lymphoma, ALL, and follicular lymphomas and non-Hodgkin's lymphomas. CAR T cell, why lymphoma is important for all of you here? So I have worked in Delhi in 85, 87. I worked in Bombay last 5 years. So if you really see North India, the incidence of lymphoid malignancies is much higher than in the South. In fact, in AIMS, we used to say CLL is only in the north, because I think AIMS that time had few hundred patients with CLL on follow-up. So lymphoma is a disease of the north. We are in the north. We should be really even more bothered about CAR T cells. So there is definitely, bone marrow transplant unit is definitely need of the day. All institutions should start it, and I personally feel we should have a good backup everywhere. So these are my activities regarding transplants in Africa. So I'm a transplant expert, medical oncologist, first private chemotherapist of this country. But my passion is, because that time I was hematologist as well, my passion is sickle cell. In last 1 year, I have seen something like 6,000 sickle patients with 7 publications on sickle cell disease. So this was my last transplant, thalassemia, and another transplant. This is my myeloma. This is myeloma from Uzbekistan. So thank you very much. Any questions? Welcome, please.
Very nice presentation, sir. We are really honored to have such a learned person about us and teach about the transplant, and the future is the CAR T cell. Sir, for some time I worked in Raipur, Chhattisgarh, and I saw there's an institute called Sickle Cell Institute. So the sickle cell disease is so common in Chhattisgarh that they have opened a Sickle Cell Institute of India next to the medical college, government medical college. And they also have very high incidence of thalassemia, sir.
So last week I was seeing patients for 3 days in Sickle Cell Institute in Raipur. So Dr. Patra is my personal friend, and I was working, I started working with him, and where Government of India, especially Prime Minister, has really given some additional money for a very special project. I will disclose after a few months, but it's a very big project, and if it happens, our country will be on the top of the world.
Thank you, sir, for nice presentation. And I think after your presentation, now we able to start BMT program soon. The one thing you shared about the challenges of donor challenges. So is any donor registry for, especially for bone marrow transplant, or it not required?
Any donor?
Registry.
No. We cannot create a registry. We don't have a blood donation registry. What are we talking?
Yeah, okay.
So there are two registries in India, bone marrow registries. One is Datri, one is DKMS, and there is one Bombay bone marrow registry. So these registries are existing, but very few numbers. Like Bombay has got only 10,000 people. Datri does have few thousand. But our population is so varied. A person from Meerut, probably for last 100 generation has not moved out of Meerut. If so, it is very unlikely that I will find a match for him somewhere else in the country. Not that it is impossible, but the chances are low. So it is good to create, definitely, ultimately if we create a registry, that is the future. But for creating registry, you and I cannot work. Social systems have to work, government has to work, the newspapers have to work. They can create this noise. Because you have to reach to public. Our level is very different. We can treat and we can't create this.
So how to counsel patient for the donors? Because mostly people understand donor like kidney donation, organ donation, they get feared.
So let me tell you frankly, if you go to a thalassemia patient, I challenge, they exactly know that brother or sister has to donate or the mother or father. They already have been educated. By frequent visits to the transfusion units, they already know everything about transplant. They will not ask you this question. Never ever. The people who are asking questions because they do not know about it. Sickle cell, believe it, not a single patient knows transplant is the solution. So it's impossible to do transplant in sickle because no patient is willing to undergo transplant. So I have a capacity in Sarvodaya Hospital. Fortunately, we have a donor available. I can do today transplant of a child below 18 years of age with below poverty line. I need all the documents. I can do it free of cost. Patient gets admitted in and out, doesn't pay a rupee. So pediatric cancer patient, I have a capacity, and a transplant children, I have a capacity. So welcome. So capacity is available, but people have to come out. So I'm offering this to sickle children, not a single has come.
Thank you, sir. Any question from audience?
It's really inspiring to hear you, sir. I'm from Day-2. I would like to share an experience. Well, at our place, we've been doing bone marrow transplant since 2016. And our team has done close to 100 transplants.
Very good.
And our cost of transplant when we started was just 2.5 lakh autologous, right? And for haplo, it's close to 7-8 lakh. And many of the patients, they receive treatment through RSBY because RSBY supports pediatric children treatment. I'm sure the same can be availed at and lately even Ayushman is. So most of our patients are supported, unlike so we do in very pretty from nearby towns. Go to Delhi, they come. Results also are pretty good, and it's much when it comes to with was a flow cycle was long back, and
Sir, please close your mic mouth के पास or nearby.
I think that's great.
Is Ayushman covering bone marrow transplant?
So bone marrow transplant, direct Ayushman coverage is not there, but there is a coverage for the treatment, which actually from Ayushman also you can get 5 to 5 lakh rupees. The next Ayushman which is likely to come is likely to have a transplant code with 10 lakh rupees. There is a Prime Minister funding available, and there is a Chief Minister funding available. So money is not a challenge today. We can actually, and especially for an institution like yours, it's absolutely no challenge because you already have a backup of 1,000-bedded hospital. So you can get really some support from there. There will be hardly 2 or 3 transplants in a month. So you can actually get the complete drug support from there. So money is really not a challenge. And this Ayushman is likely to increase to 10 lakhs. Prime Minister Relief Fund up to 2 to 5 lakhs. Chief Minister Relief Fund 2 lakhs. Ayushman card 5 lakh. Government of Chhattisgarh gives 20 lakhs. So every state has got some funding. So don't wait for funding. Start your project.
Okay, thank you, sir. Thank you.
Thank you very much.
Thank you. Thank you, Dr. Dinesh Pandhirkar, for generously sharing your knowledge and experience with us. We will now delve into frontiers in glioma management, cutting-edge insights from neurosurgical lens, led by Dr. Abhishek Katyal, Assistant Professor at JP Pant Hospital. This session will be chaired by Dr. Mahip Singh Gaur, Dr. Abhinav Bansal, Dr. Arun Sharma, and Dr. Nidhi Agarwal.
Okay. A very good morning to all. I will first of all,
Good morning, everyone. I'm Dr. Abhinav from Subharti. I'm privileged to represent as a chairperson for this session. Would like to introduce our talented, young, robust neurosurgeon, Dr. Abhishek Katyal. He is from a premier institute. He is working as an assistant professor at JB Pant. He has completed his MCH from the same institute. He is actually a very versatile surgeon with special interest in surgical oncology. He is also a AO Spine Fellow. He is also has a special interest in neurointervention, and he has a dozen publications in his name with various posters and paper presentation at various conferences. We welcome you, sir, for this important session. We welcome from Subharti family.
thank you very much, sir, for the kind introduction. So, first of all, I would like to thank the organizing committee of Subharti Cancer Institute for giving me this opportunity to share our surgical experience on this platform of cancer updates. So now we will be talking about the frontiers and recent advances in the glioma management from a neurosurgical point of view. And a point to be mentioned in the beginning is that we all know that gliomas, they are a very vast clinical entities where just like depths of an ocean, where extensive and exhaustive discussions can take place, starting from surgical part to chemoradiation and then histopathology. So we will be restricting our discussions mainly on the surgical part, and I won't be going into the details of chemoradiation, in which we already know that our senior oncophysicians and the radiation experts are already having their domain, which are very well versed in that. So, to begin, the gliomas, they have been classified recently by the WHO. The earlier 2016 classification was modified into in 2021, and they classified the gliomas into astrocytomas, oligodendrogliomas, and glioblastomas. And based on this, the grading has been constantly increasing, and the IDH mutant and IDH 1P co-deletion wild type, these are all the molecular classifications of the gliomas, which have their own prognostic significance, which we will be discussing in the upcoming slides. So this is the list, this is an extensive list which has been given by WHO, and this list goes on and on and on, but we will be focusing mainly on the first 3 or 4 entities which are usually encountered in clinical practice. So the gliomas, to see the cumulative survival, the low-grade gliomas particularly, which are grade 1, like pilocytic astrocytomas, and they are having very good survival rates of 96% at 10 years, and the survival rates, they keep on gradually decreasing as the grade of the gliomas increases. So the poorest survival rates of at 5 years are of the GBMs, that is glioblastomas, where 1 to 2% at 5 years, and most of these patients without treatment, they survive only for 4 to 6 months. And even after surgery and debulking these tumors, these cases, they survive for maybe an year or an year and a half. So now coming up to the management of the part of the gliomas, the surgical resection. This is the first and the foremost step in the management of any glioma which has been encountered, and the literature also supports the same thing. And then obviously comes the role of radiation and chemotherapy. Now this observation is a very controversial entity, a treatment protocol in amongst the various surgeons, because according to the literature also, if you are getting a lesion, it has to be either biopsied or it has to be resected until unless it is somewhere lying deep in the inaccessible or difficult to access areas of the brain. So now in neurosurgery, what to do? One has to decide what to do. One has to be very clear what is to be done and how it has to be done. And there is no scope of mistake in this case. So the rationale of surgery is one has to aim for a cytoreductive surgery and the maximal safe resection. These are the two main founding pillars of any brain surgery. If we are encountering a case of gliomas, cytoreductive means the maximum amount of tumor has to be decompressed and it has to be removed to decrease the tumor burden. Along with that, the safe word has been highlighted in red because the brain is not an organ, it is a very unforgiving organ. If we make mistakes, then we'll end up in trouble. So the maximum safe resection has to be done, and without giving an additional deficit to the patient. And according to that, one has to be well versed with the macroscopic appearance of the tumor, which can hamper the complete resection by its invasiveness, vascularity, and consistency. These gliomas, they have the tendency to infiltrate deep into the parenchyma, and it can definitely, and if they are located in eloquent areas, so they can definitely hamper the complete surgical removal. Now, obviously, one has to be acquainted by these terminologies like gross total, supratotal, near total resections, and obviously the more the percentage of resection, like more than 70%, the survival rates, they become better. The more tumor we remove, obviously it has been supported many a times by literature, it is best for the prognosis of the patient by increasing the overall and prognostic survival of the it. And then subtotal resections, they mean, at least by surgeon discretion, at least more than 10% of the tumor if it is being left. That means the contrast enhancing part, that means subtotal resections. Near total, it means less than 10%. And gross total, it means we have been able to, as per the intraoperative finding, we have been able to remove the full tumor. And supratotal means it is an additional and again a controversial treatment protocol where 2 centimeter extra margin of the tumor of the we are removing, which is there in the which is the edematous part, which is apparent in the FLAIR imaging of the MRI. Now, recently the treatment is not simply based on cutting. We have been focusing on the resection has been based on molecular markers, and in which the IDH mutant gliomas, they carry a good prognosis, and then again similarly they have been easily and more amenable to surgical resection in view of superficial locations, and the prognosis is also good with IDH mutant type variants, and the poor prognosis is there and the good prognosis is there in MGMT methylation variants, whereas the IDH wild type, they carry a bad grim prognosis. So, rationale of the surgery, pre-operative imaging is of paramount importance. The operating surgeon has to be very well versed in reading the MRI scans and for the pre-operative workup of the patient, because of the MRI also is only going to tell us that how much the tumor, what is the tumor, and how much tumor has to be removed. So conventional contrast MRI brain, that gives, that is the baseline investigation, where we can see this low-grade gliomatous lesions. They will be appearing hypodense and like seen in the right occipital region, hypodense in the CT imaging, and the up image, the image which is up, it is a flare image. The image which is down, that is the T2 weighted image, where the lesion is seeing white color, that is T2 hyper intense, and there is a T2 flare mismatch, where in the flare image we can see more edema as compared to the T2 image, which is the characteristic of low grade lesions. So the question comes here: can we really predict the molecular type and consistency of gliomas before starting the surgical treatment based on preoperative MR imaging? The answer is again yes. And this things carries a particular importance because it's based on seeing the MRI only, and before getting the histopathology report, one becomes alert that this is the pathology which we are going to deal. So this recently, these new, the high-grade lesions which are there in the top right corner, you can see the necrotic core is there, and along with that, edematous surrounding, more edema is there. They correspond to the high-grade lesions, and the low-grade lesions, the contrast enhancement will be very less, like in the leftmost pictures. Again, like we discussed earlier, and now to focus on this ADC mapping is a sequence which is very helpful in delineating these tumors, where the low ADC values, means the lower ADC values, they will be like this black lesion which is there in the second column, third row. So low ADC values, they correspond to high grade malignancies, IDH wild types, and the low and the high IDC values, which is appearing little whitish, which are the image which is on the left side. So they indicate a good prognosis and low grade tumors with IDH mutant types. And similarly, MGMT methylation, which carries a good prognosis, there will be IDC value will be high, and unmethylation, the grading, the ADC mapping will show a black color, low values, which indicates a grim prognosis. So now these are the new modalities which are there with us, like MR spectroscopy. All these modalities, they help us in locating the lesion and differentiating gliomas from other lesions, like how to differentiate gliomas from other cystic lesions which may mimic a glioma. So gliomas, this is based on the various tissue metabolites in the difference in the tissue metabolites between the gliomas as well as the normal cerebral parenchyma. The choline levels will be high in glioma patients, in the glioma cases, so which will be detected by a choline peak. And similarly, these areas will be divided into voxels, and this graph will show that the choline peaks are high in the glioma, the region where the tumor is there. So again, then comes the cortical mapping, the brain mapping, where we map the important eloquent areas of the brain based on the bold sequences or the blood oxygen levels, where the increased neuronal activity is there, mainly like in the supplementary motor cortex area, the primary motor cortex area, the visual areas and the speech areas in the brain, which are being marked in the blue color. So then comes the DTI, or the diffusion tensor imaging. Now this is to delineate the white matter tracts which are growing down in the brain, which are responsible for the power control basically in our on the limbs. And these are the white matter tracts which they get infiltrated by the glioma tissues, and we have to delineate the corticospinal tracts, the articulate fasciculars, optic radiations, and all these by preoperative imaging. Now here we can see the lesion. Here we can see a large thalamopedunculaar mass, where these fibers, white color fibers, can be seen on the DTI imaging. The fibers have been displayed laterally, as we can say in the image, in the coronal image which is there down. So this yellow mark is showing that this appears to be a more feasible option to attack the tumor. But then again, if we go by this route, we'll be cutting and going through all these white matter tracts, which is not going to be good. So making interhemispheric and transcallosal transventricular approach a preferred approach in this case. So MR perfusion, again, these are all modalities which show based on the relative cerebral blood flow that to differentiate the high acting areas of gliomas apart from the necrotic areas. Then awake craniotomy, obviously this incorporates the concepts of both brain mapping as well as the diffuser tensor imaging, where where the patient is in a constant sedation, and we, before venturing and before taking out the tumor, we give electrical stimulation to that part. If it is getting stimulated, mainly in the speech areas, somatoform areas, and before cutting, we just give impulse and see if the deficit is coming or not. It will indicate that we have to stop there. Now to come with the intraoperative, now seeing the this is the preoperative imaging. Now once we have started the surgical procedure, now we have to be very careful. These are the protocols which help us, and these imaging techniques which help us in delineating the tumors. This is an intraoperative ultrasound where we usually place a probe like this, and then where we can see the difference in the echogenicity of the tumor, which is there on the right, and the sulci and the brain parenchyma, sulci gyri are seen on the right, on the left side. So this differentiates between the tumor and the brain interface and gives us an edge and the margin from where we have to start the tumor decompression. Then again, this shows the tumor which has been removed by the ultrasound. It is again an ultrasound image which shows a tumor there lying there in the deep in the thalamus with a normal sulci gyri pattern of the cerebral cortex seen, which is there in the superior part of the image. So the intraoperative fluorescence imaging, this is a concept which is gaining importance worldwide, because the baseline of the fluorescence imaging is that there is a preferential staining of the glioma tissues with these dyes, and they can be based on the passive targeting, due to the enhanced blood-brain barrier which is getting destroyed in the glioma patients, and ICG and fluorescein, they follow this mechanism, as well as this 5-ALA dye, which is a which due to differences in the metabolic processes which are happening in the glioma as compared to the normal brain parenchyma, and due to the accumulation of this dye goes and gets accumulated into the tumor parts, and then again molecular targeting techniques are there. So the idea is that this dye will go and it is going to stain that part of the tumor where preferentially that part of the tumor in which we are interested, because the surgical resection is totally based on operating surgeon's discretion. How is he able to see intraoperatively how much tumor is removed? This can definitely it can be a subjective finding, and mistakes can happen. So these and then one has to adjust the light of the microscope. In the white light, the normal white light we are not able to confidently see, but once we turn on the blue light according to the spectrum of the dye, we can see the glistening pink tumor and we can remove it properly. So again, in white light, it is very difficult to differentiate between the residual tumor, and again, once we follow the fluorescence microscopy, the tumor is getting removed as shown in the post-operative imaging. Now this technique again helped us in removing a tumor which was located in the left motor cortex area, and near gross total tumor excision was possible because of the fluorescence technique. This is again a near total tumor decompression based on the fluorescence imaging. So now neuronavigation, again, it is it is a technique where we use to target the lesion which are inaccessible and deep in the brain, which give us a trajectory to take out these lesions. And then this is the fiducial markers which we use, and for mainly those lesions in which we are planning a biopsy or which are difficult to reach. Electrocorticography, this is the tumors of glioma which are being associated with epilepsy. We place electrodes over the cortical surface. We record the epilepticogenic impulses are recorded there on the screen, and post resection we again place the electrodes, and then we see no impulses are coming. It means the part of glioma which was creating the epilepticogenic charges have been removed completely. So the post-operative assessment is based mainly on this Rano's criteria, that is response assessment in neuro-oncology, where a complete response we will see on the post-op imaging. There will be no contrast enhancing lesion, the patient will be stable, whereas a progressive disease will say more than 25% growth is still there, and patient still getting neurological deterioration in spite of being on corticosteroids. So this again, the literature finding, they say that they have reported that MRI has to be done at least 48 hours after the surgery to reduce the unspecific contrast enhancement after the surgery has been done. Recurrent gliomas, now this is a point where one has to, it's worth mentioning because they are a nuisance to everyone, including the surgeon as well as the radiation oncology parts. So the treatment protocols of recurrent gliomas are very much controversy is there. The literature is full of supporting evidences in both the scenarios. The here it says that at least second surgery is well justified and it gives survival benefits, but the more number of surgeries, third surgery or fourth surgery, they are very individual decision of the operating surgeon depending upon the neurological status of the patient. And obviously, for a better health-related quality of life, then again one has to subject the patient for chemoradiation. So this was again a case of now worth mentioning case. This patient was operated somewhere and the biopsy was GBM. The tumor had regrown. The patient presented to us in a drowsy condition, and then as we can see, the neuroimaging is showing a very irregularly and solid cystic areas with necrotic regions in between, along with the irregular patchy contrast enhancement, a dirty looking tumor. And then after that, where neototal resection of the tumor was done. Now, this second case. Now, this case is worth mentioning because the idea is that everyone, because we usually think that if the tumor is there, then why not simply take a biopsy and send the patient to radiation experts then for further management? Why to unnecessarily take stress and give additional deficit to the patient? So the thing is, this patient, he was operated in some part of the country where a small biopsy of the lesion was taken, which came out to be GBM grade 4, and the patient was subjected to chemoradiation, and he took radiotherapy for at least 3 weeks, and after that, they noticed that the lesion has been growing and growing since then, and reaching this monstrous size, even eroding the skin. The patient, then again, due to the reluctance of reoperating such patients, there is a general reluctance to retouch these patients. This patient was referred here and there, sent here and there, and finally he showed up in our OPD in a neurologically deteriorated condition in drowsy state, and he was where there was a scan of this patient which is showing grossly the tumor is involving the deep skull base temporal region reaching up to the brainstem, and it is pushing up the temporal lobe out and even lifting up the bone flap. So again, this gross resection of wide craniotomy was done, the bone flap was thinned out, it was removed, and it was very highly vascular tumor, but thankfully the patient survived the case and he went well. And then, so again, we recently they have started reporting that preoperative biopsies and simply sending the patients to radiation is not always the solution, can be sometimes detrimental. So to cool things now, this is then again case where a beautifully looking simple plain looking lesion is there in the left frontal region, which was being removed by a small beautiful good looking supraorbital keyhole approach, small craniotomy where the tumor was decompressed because it was friendly to us and it came out easily. So the purpose of this picture is to show that the vast spectrum of gliomas, where starting from big craniotomies to big decompressions, and then on the other part of the end of the spectrum we have these small craniotomies where lesions can be taken out if they are helpful, if they are cooperative to us. So now these are the recent advances now which are upcoming, where the exoscopes are being used, intraarterial chemotherapies, and obviously other like intraoperative in the tumor cavity keeping chemotherapeutic agents, stereotactic biopsies, and intraoperative MRIs. Now, to the key message of this discussion is that the gliomas, they are very complex modalities and entities which carry, obviously they carry grim prognosis in higher grades, and it is a multimodality approach where surgical resection is of paramount importance and the primary line of treatment. The aim of the surgery is to reduce the tumor bulk. The cytoreduction has to be done, and maximum tumor has to be removed. But again, safety is the priority always, one should always strive to remove the full tumor, gross tumor resections, but then again, one has to resist the temptation of digging deep into the brain and in the hope of achieving a good post-operative scan and adding unnecessary post-operative neurological deficit to the patient, which may not be adding just burden to his overall and progression-free survival. So, thank you.
Thank you, Dr. Kadyal. Very good presentation.
Thank you, sir.
And I think you have very heroic surgeries you have shown us. After a very long time, I have seen such large tumors resected
Yes, sir.
and operated.
Yes.
But actually, it's pathetic situation. Most of the people refuse
Yes,
such
sir.
patients, and ultimately they land up with the government setup. Now, problem is that you said that standard way is chemoradiation. But I think now emerging role is of radiosurgery.
Yes, sir. Yes.
Time has come when we should treat some of these tumors directly with SRS.
Yes, sir.
And
Yes.
then wait so that we can repeat treatment.
Yes.
If you give extensive surgery, radiation in first go after surgery, then sometimes there is no scope of any further radiation.
Yes, sir.
So we have to select cases. Personally, I have patients means follow up for 12 years with glioblastoma, and they are maintaining only on radiosurgery. So with temozolomide and good radiation, we can actually extend life. So on the first visit, we should not let the patient say that you have now tumor and you are gone.
Yes, sir.
Hope is very important. A good surgery, good radiation, maybe we can save many of these patients and give good quality of life.
Yes, sir. Sure.
Dr. Abhishek, very good talk and very elaborative and finished within time. So you covered all the latest techniques. Even I was not aware that intraoperative ultrasonography and fluorescence imaging, and that's all. So I just want to ask one question: where do you do super total resection?
Supratotal resections, ma'am, the aim is always to achieve a gross total resection. Supratotal resections are mainly done in such cases where the tumor is involving deep parts of the brain, like thalamopedunculaar lesions, lesions of the brain stem, or they are going deep and involving into the cavern. Suppose the glioma of the temporal lobe is there, it is going deep and involving the cavernous sinus. So it's better we leave then all these things are theoretical. More than 10%, less than 10% is just for academic theoretical part. Once intraoperatively, if we see that we are approaching the cavernous sinus or some major neurovascular structure, we leave a part of tumor there. So in those cases, we do supratotal. Otherwise, gross total and gross total resections are done.
Sufficient. Okay. Thank you so much. Thank you.
Thank you, ma'am.
Thank you. Thank you.
Thank you, Dr. Abhishek Katyal, for your invaluable contribution to the symposium. Your dedication to advancing knowledge and fostering meaningful dialogue is deeply appreciated, and we are grateful for the opportunity to have had you as a speaker. Now, I would like to invite Dr. Mukesh Maheshwari to present a token of appreciation to our esteemed speaker and respected chairpersons.
I would now request Dr. V.B Verma, Consultant Max Hospital, to share insights on bone and soft tissue tumors, new treatment approaches. This session will be chaired by Dr. Gyaneshwar Tonk, Dr. Shipra Gupta, and Dr. Soren Shishak. Welcome, sir.
Good morning, ladies and gentlemen. In this session, we are having Dr. V.B Verma amongst us. He is Associate Director and Head Orthopedic Specialty of Max Super Specialty Hospital at Vaishali. He is an undergraduate of BJ Medical College, Pune. He has vast experience on musculoskeletal oncology. He has been a fellow in Tata Memorial Cancer Institute, Mumbai, Madras, and he has been a member of so many associations, and he is practicing on musculoskeletal oncology at Max. I welcome you, sir, on behalf of Subharti Institute of Oncology Department.
Thank you. Good afternoon, everyone. First, I want to thank the organizing team for giving me this invitation. So, yes, I'm practicing this bit rare specialty of orthopedic oncology. So I practiced orthopedics for 7 years, and then I went for training to TMH, Mumbai, and then I started this department at Max Vaishali and Paparganj. So these are the 2 units where I work. I head the department. This is our entire oncology team of East Zone, and of which this is our close group of musculoskeletal oncology, where we have a dedicated MSK pathologist, radiologist, and pediatric oncologist who specially look after sarcomas. We also have a 1-year fellowship program going on for last 5 years in orthopedic oncology, one of the very few programs in the country. Basically, what we deal with is all type of benign and malignant bone and soft tissue tumors, metastatic bone diseases, many interventional procedures like radiofrequency ablation for tumors, and around 10 to 20% of the cases comprise non-oncological like complex reconstructions, large bone defects, resistant type of infections, revision joint replacements, which are routinely as a challenge to orthopedic community. So when I went for my training in oncology, I realized few things which are very different how we are taught as an orthopedic surgeon. So as an orthopedic surgeon, we were taught like we have to directly reach to the bone, don't go into the planes here and there, dissect things, be away from vessels and nerve. But in oncology, I think the first principle is that you need to take wide margins, especially in sarcomas, and for which you need to identify in a plane where you protect the important critical structures and then remove everything with a wide margin. So just to show you, this is a total knee replacement, routinely, which is like articular surface resurfacing, where you remove the damaged part, the arthritic part. But if you see the resection in tumors, it is not just the removal of the articular surface. It removes entire joint, bone, supporting surrounding structures of ligaments, stabilizing structures, and the muscles as well, sometimes even the skin. So we need special implants which are called megaprosthesis. A common procedure like hip replacement, where you replace the ball and the socket of the hip. But if you see in a tumor, we remove the entire bone right from not just the joint, but entire length of the bone, capsule, everything. So we'll take some examples, otherwise it's theoretical. So this was a young guy who had osteosarcoma of the proximal tibia. So normally in sarcomas, we take a margin of 2 to 3 centimeter. We remove the tumor with wide margins. Now what is this wide margins? We all have read in the books with a normal anatomical barrier. But let us see this with this example. So this proximal tibia with a pathological fracture, once it is removed, you see the articular surface is totally intact. This meniscus is on top of it, intact. This patient also had a fracture. The skin, the previous surgical scar of the biopsy, somebody has done an open biopsy. Normally we do just a needle biopsy. The muscles all around are intact. And when we move, in spite of having a fracture with hematoma, when we move, not a drop of blood should come out. So like the tumor contamination in this hematoma is well contained with a normal muscle layer. So once a tumor is operated like this, the chances of recurrence are minimal. Normally we say 5% risk of recurrence, local recurrences in these cases. Nowadays we have the availability of these implants, and these are off-shelf modular implants. If I want to do a surgery tomorrow, I can plan it well. And normally people focus just on sometimes resection or reconstruction, but a soft tissue reconstruction is of paramount importance. When we operate such a large volume, we need to cover it well to give the patient a good function. So this is the video. Now this boy is almost going to get married when I operated him somewhere in 2016 or 17 when I started. This is another case, a young lady with a large tumor of the proximal humerus, and then she was advised for 4/4 amputation because looking at the size of the tumor, you see the entire bone is gone there. It is all replaced by the bag of the blood because of the vascularity of the tumor. So we started on chemotherapy, and you can see the gradual response, how the tumor started shrinking. This shows the importance of a multidisciplinary approach in oncology. And then we were able to do a limb-saving surgery in this case, and she had a safe surgical and oncological outcome. So a lot of things have changed. In tumors especially, amputation is no more the treatment of choice. We are able to do limb saving in more than 90% of the cases. Sometimes we see the tumor involving the entire compartment, and people advise for disarticulations. But like this boy with a lesion which was with a pathological fracture, and the periosteal reaction you can see reaching up to the lesser trochanter. Also, this shows the importance why we should take the imaging of the entire length of the bone. Like he came to me with just half MRI distal femur and planned for limb salvage with a distal femur resection, but proper imaging showed that the lesion was quite high up. Now in these situations, we do a total bone replacement. You can see not just the knee joint, but knee to hip, entire bone is replaced. You can see the neurovascular bundle which is overlying there. This is the intraoperative video where we have replaced this with this implant. Depending upon the margins, the muscles are removed. We need to assure that it is well stabilized as well, both at the hip and the knee joint. We call this a constraint implant. So the hip is good, the knee function is good. So it's not just the oncological outcomes, we check also on the functional aspect as well. So this is the implant where you see whatever is required, we can replace any length. If it is 10 centimeter, 20 centimeter, 40 centimeter, we have this modularity in this by which we can replace the resected part of the bone. So this is the same boy. So this was the immediate. Normally we make the patient weight bear and walk from the first post-operative day. If I operate today, from the next day patients are walking, especially when done with these implants. And the functional outcome depends a lot, like I said, on the good soft tissue reconstruction. So this boy is an independent ambulator now. So these were some cases where we use mechanical methods like implants and prostheses to resect and reconstruct. Now the trend is more towards biological reconstruction, which I'm a very big fan of. This young girl, 10-year-old with Ewing sarcoma of the distal tibia. Now, she was advised for amputation at multiple places. This is one of the first case. I think Dr. Arun is also there. We did together. So when she presented to me, you can see that below the tumor mass, the pointer is weak. So you can see that the physis is preserved. So what we decided that we will do reimplantation of the same bone after sterilization with radiation. So we remove the tumor with wide margins. We take it out, then we send it for radiation therapy while the patient is on table, anesthetized, and Dr. Arun was there that time with us, and inside the OT while the patient is anesthetized, we give the sample in a sterile container. It's taken down to the radiation department where 50 gray is given. The bone is brought back and we reimplant it. So the advantage is that this is a biological procedure, avoids the use of any prosthesis. We have just used a simple plate to fix it in its place. Once it heals, it lasts for lifetime. Disadvantages, this bone is now completely dead when we take it out of the body. It roams the entire world, again comes back with chances of infection, pathological fracture, all these things are there. So we started thinking, what else can be done? Can we do biological technique, sterilize sarcomas while it is inside the body? And thus, we have come out with pedicled cryotherapy. So we did first surgery in India. I did it in 2017. This was devised by Japanese group, somewhere in practice since 2010 around. A similar case with sarcoma of the distal tibia. We could have done the same thing. We could have resected, reimplanted after radiation. But here we tried something different. So you see, rather than removing the bone completely, we first dissected the neurovascular bundle. We did only single osteotomy on the distal side with a margin, and we protected all the neurovascular bundle. Now, many of you must have seen in some fairs this liquid nitrogen. They even give it in pan, and it all smokes out. So we use this thing for killing cancer cells, actually. So you see, it has a temperature of minus 190 degrees centigrade. We dip the tumor cells completely inside so that it kills all the cells, normal cells, cancer cells, everything. But the good part is that we have not cut the bone completely. It is not completely osteotomized. So vascularity, you can see from the other end, is still intact. Now it is a special how we do it: 20 minutes of liquid nitrogen dipping, 20 minutes of air drying, and then thawing with distilled water. And then we reimplant it back, put it back in its position. Just similarly, a single plate, simple plate, what we use for trauma, 15,000 plate. And you can see the osteotomy there. It's immediately. This is almost 3 months, and by 6 months, it has completely healed and united. A biological technique to get limb salvage, economical, patient goes back to routine functional activities. Now, pelvic resections, these are one of the most complex tumors where majority of the people, they don't want to go in and remove the tumor, and sometimes directly radiation is offered, but which is not the treatment of choice in sarcomas. Where we can operate it and remove it, we must try and remove that. So this was a young boy with malignant GCT of the pelvis, and everybody refused him surgery, was roaming around for almost a year. You can see a big stone formation because of the back pressure over the kidneys. So we started him on chemotherapy and denosumab, and you can see how gradually the mass ossified well. And we use nowadays computer navigation. We have 3D printed zigs and implants by which we can precisely make a model of where we are going to resect with preservation of the joint, of the hip joint, so that not just oncologically we are precise with our margins, but even functional outcomes are good. So intraoperatively we resect everything. We preserve the critical structures, your internal iliac vessels, external iliac vessels, ureters, all these things are preserved. This is considered a major surgery. And now he has, I think, more than 6 years follow-up now. So he's doing fine. So you can see here, we were able to preserve the joint with the help of navigation and 3D printed zigs. When it comes to adult, we have a lot of options, but in pediatric population, they have a smaller size. The amount of bone that is left after resecting the tumor is also small. They cannot accommodate normal implants. So it is challenging, and that's why majority of the pediatric population is offered amputation. But I think the scenario is changing. If you are well versed with all these techniques, the biological and other things, we have changed the scenario. Now, still in pediatric population, we attempt limb salvage in more than 90% of the cases. So this is an 8-year-old girl with osteosarcoma with pathological fracture. Now, coming to pathological fracture, I think this is also an important message. Sometimes patient presents to us with pathological fracture is directly advised amputation. That should not be done. We should always splint it, give it chemotherapy, and majority of the cases they heal well. And we can get a good margin, and we can do limb salvage surgeries even in those cases. Now, at 8 years of age, if we resect the distal femur, there is going to be a lot of limb length discrepancy because the growing end is lost. So now we have in India indigenous expandable implants, which means these implants will sit inside the body, they can expand in length as the child will grow. Initially, we used to import it from UK or US, and the cost was tremendous. Now we are getting all this in India at almost 1/10 of the price for the implants that we get imported. Of course, quality cannot match exactly, but for somebody this type of implants can save the limb and has a huge impact in the future on their psychosocial life as well. 8 years when we operated her, and this is the implant what you see. It has a growing potential there. Now you can see she had some fractures, some shortening, and that is how we do expansion. There are two methods. One is minimally invasive, where you just need to rotate a screw, it will expand the bone. The other is where you don't do anything, you just put the leg inside electromagnetic coil and the leg will expand based on what setup it has. Now this is her follow-up. She had sent her video. So she has stopped coming now. She is from Afghanistan, and after all these political situations, but she is in touch. Till 3 years back, I think the youngest child I operated with bone sarcoma was 4.5. But last year I operated this young boy who was just 2-year-old. And just when he started walking, the parents noticed that he's limping, sometimes complains of pain at night. And you see here, this was the osteosarcoma. The challenge was, at this age, even the implants, customized implants will not fit well. The options are either go for amputation or go for rotation plasty. You remove this bone, put the tibia up into the hip, rotate it 180 degree. So it's like a partial amputation. Here you can see the periosteal reaction is reaching just up to physis. So this was really a challenging situation. What we did, we wanted to have some margin, like the last cases you saw. The tumor is reaching just up to the physis, so we wanted there should be, if we can get some bone amount there, a normal bone, on which we can take a cut and reimplant this bone back. So this is called Canadell's technique, where we use simple external fixator, distracted the physis. It's not into the tumor, it is into the epiphysis. We distracted the physis so that we could get some normal marginal bone. And then in this case, we reimplanted this bone after sterilization with radiation, and we use vascularized fibula, which means the fibula bone along with its growing end. You can see in this age we expect that the child will have problems while growing. So we removed the fibula with the upper growing end and reimplanted it into this bone with the vascular supply so that it is a live bone. And this is what it looks like. So now this is almost 15 months and the child has been started walking now, full weight bearing. So these type of surgeries are quite complex and challenging. Sometimes may take 10 hours or even 15, 18 hours. But once we see the impact they have, the family, the happiness on the patient's face and they have on the family, this is what is the driving force for us to go on. So one of the common myths is that once bone cancer sarcomas are detected, the treatment of choice is amputation. But I would say we are able to do limb salvage in more than 90-95% of the cases. The only case I think where I go for amputation is where in a sarcoma, in a cancer, somebody has grossly contaminated the thing. They thought it is a benign tumor, put it a nail, reamed it or do a curettage. Then once the tumor seedling is everywhere, it's not safe from the patient perspective. The second, when the patient, because of, in India, the diversity is so much that patients, they are grossly ignorant. You saw what the size of the tumor in the shoulder was. So they did not have proper access to healthcare. They themselves were ignorant until it is so much burdening that they are affecting daily life. They do not consult a doctor. So these are the situations we face, definitely. So those situations where we have to go for amputation. Otherwise, big tumors, we can do, even if vessels are involved, nerve is involved, we can do tendon transfer, muscle transfer, vascular grafts can be done to save the limb. And talking about the survival, a lot of things have changed. Many people tell me now it's bone cancer, it's gone. Or sometimes there is a metastasis lung. They say nothing to do, leave him alone. So that's not the situation. Even if there is lung metastasis, in sarcomas, you go ahead, be aggressive. If you leave it 100%, the patient will not survive. But if we give proper multidisciplinary approach, we give proper chemotherapy, and we do primary surgical resection, lung metastatectomy, all these things, patient have a probability of survival. He may be cured potentially. Of course, The successful outcomes in a non-metastatic scenario is 75 to 80. Even if it is metastatic, the chances are not zero, 10 to 20% may be possible if we are able to get complete removal of the tumor mass. So with this, I end my talk. Thank you very much.
Thank you, Dr. Vivek, for nice presentation of these fancy resection and fancy implants of megaprosthesis reconstruction by them. I want to know, in this era of targeted radiotherapy, does we still require excision and radiation of the bone and then reimplantation of the bone? Can we don't apply targeted radiotherapy to these bones in situ? Number one. Number two, what about the recurrence in these irradiated bones? Because they are really a challenge, because these sarcomas are in the small, younger age patients. So what about that?
Yes, sir. So first thing is, the biology of sarcomas are quite different. I mean, we consider for definitive radiation only in situations where we are not able to get R0 resection. Tumor is not, we are like in sometimes in spine where there is intraspinal extension. So in those situations, we may think of using definitive radiation. It is also histology based. Like if we consider all the sarcomas, osteosarcoma and chondrosarcoma is quite radio-resistant type of tumors compared to Ewing sarcoma. Even in Ewing sarcoma, the best results outcomes are with complete surgical resection, and sometimes in such cases where we may have to add up radiation in a neoadjuvant or adjuvant setting. This gives the best outcomes. Considering only radiation versus radiation plus surgery in histology sensitive types, the surgery plus radiation always has a better outcome than definitive radiation. Now the new radiation machines like proton therapy, heavy ion therapies, they have shown a promising results. We have in Chennai, Apollo, and my friends are there, some seniors are there from TMH, but when I talk to them, it is not a magical thing which has come, the way it is being produced. So we need to balance it. What suits well. Of course, when we are not able to resect the tumor, then probably you may add up radiation as a modality in those situations. Now coming to the part of local recurrence, if we do a limb salvage surgery with clear margins, like I said, we should have a good margin. The chances of local recurrence are same, like it can be achieved with amputation. We always counsel up to 5% chances of local recurrence. Whether we sterilize the bone by radiation therapy or pedicle cryotherapy, these are proven techniques. We are not in the experimental phase. These have been proven for more than 2 decades that this effectively kills the tumor cells in vivo, in vitro. So we are completely free. I think if there is a local recurrence, we need to see why there is a local recurrence. Is it because the surgical margin was compromised somewhere? That may lead to local recurrence rates.
Okay, thank you.
Thank you, Dr. Vivek. I have a question. Do you use circulator or some kind of prognostic tools to guide in some kind of personalized follow-up care?
Sorry, ma'am, what circulator?
Do you use circulator or some kind of prognostic tools to guide in personalized follow-up care?
Yes, it is available online, and sometimes when the patient wants to know the prognosis, so we can show them on a circulator like how the recurrence, event-free survival, everything is going to be there. But not routinely in every patient. We have, based on our experience, we counsel them.
Sir, I feel it's very wonderful the work you are doing, because at many setups we don't see surgeons actually go for inaccessible sites and they send the patient for chemotherapy or radiation therapy. Most of these patients end up having metastasis. More than 50% of the patients end up having metastasis. And the median overall survival is very less. It's even less than 2 years. So if the surgery is being done, especially in the tumors like chondrosarcoma and osteosarcoma, like you said, then it's very wonderful that actually patients can be salvaged at some point of time.
Yes, I feel the problem is lack of awareness, not among the general population, but even among the orthopedic surgeons, because primarily it goes to orthopedic surgeons. So I've been working constantly on this for last almost 8-9 years. I go to Patna every month, and a lot of things have changed. Patients there are totally non-affordable. They have Ayushman scheme, and we have been doing limb salvage surgeries under these Ayushman schemes also. I go to Indore, and slowly and gradually I think the scenario is changing. Now we see a lot of references. People are not just going inside doing experimental things, but timely identification and referring to sarcoma centers are something which we ideally should be the option, how it should be practiced.
Thank you, sir.
Thank you. Thank you very much. Thus we sum up this session. Thank you.
Thank you, Dr. Vivek Verma, for your dedication and willingness to share your expertise with us. Your passion for your work was palpable, and it served as inspiration to everyone in audience. Now, I would like to invite Dr. Sachin Agarwal to come forward and present a token of appreciation to our esteemed speaker, Dr. Vivek Verma. Thank you.
Moving on further, I would like to call upon stage Dr. Anjali Khare, Professor, Subharti Medical College, who will shed light on the topic Role of Next Generation Sequencing in Precision Medicine. The session, it will be chaired by Dr. Shivaji Jain, Dr. Anshul Gupta, Dr. Dipali Mittal, and Dr. Monica Singh. I'd like to call all of you on stage, please.
Good afternoon, everyone. I am privileged to introduce Professor Anjali Khare, who is alumnus of MLN Medical College, Allahabad University, at present Professor and Head, Department of Pathology, Subharti Medical College. She has many publications to her credit and has held various administrative posts. She has a keen interest in teaching and has been a thesis guide to many postgraduate students and STS-ICMR research projects. Genomic research has come a long way from the Human Genome Project, which took nearly a decade, to the present day next generation sequencing. Although still not commonly available in many teaching and non-teaching institutes, it is the future of precision medicine. So I invite Dr. Anjali Khare ma'am, Professor and Head, Subharti Medical College, to enlighten us on this very important subject.
Thank you. Respected chairpersons, my seniors, colleagues, and dear students. So today, in coming 20 minutes, I will talk about next generation sequencing in precision medicine. So with the knowledge of human DNA and the variation in DNA sequences, germline mutations and somatic mutation, with the knowledge and with the technology, we have a revolution in healthcare. Nowadays we talk about customized shoes, we talk about customized clothes, then why not about customized healthcare? So what is precision medicine? Precision medicine takes into account a person's genetic makeup, environmental factors and lifestyle to treat an individual. Then in this, the treatment is tailored according to the unique need of individual, and we use the examples of precision medicines are mainly in cancer therapy and also in cases of antimicrobial resistance. So what is next generation sequencing? For next generation sequencing, we use we should know about Human Genome Project. This project was started in 1990 and it ends into 2022. It took about 32 days and we got reference DNA. Now in next generation sequencing, millions of DNAs are sequenced. And then what happens to this raw data? We use bioinformatics to analyze and to interpret this data. And by the interpretation, we can know about the structure of genome, we know genetic variations, we know gene activity, and we know changes in gene behavior. So for the mapping of reference DNA, it took 32 years. But now, with the help of next generation sequencing, we can produce DNA fragments within a day. Millions of DNA fragments within a day. So in what is next generation sequencing? Why we are calling it is next generation sequencing? So in Human Genome Project, the sequencing used was very basic, but the fundamental sequencing known as Sanger sequencing, in which the data output per run was very low. But now you can see that in 2010 and 2015, we are in the era of second generation and third generation sequencing, and in this era, the output per run is very high. That means the technique has become rapid and with high throughput. So this is next generation sequencing. We are producing many strands of DNA within a day, and the raw data is analyzed. So what are the applications of NGS in precision medicine? What are the areas? So we can use NGS, we can apply NGS in cancer genomics and personalized oncology, in pharmacogenomics and drug response prediction, in rare genetic disease diagnosis, in infectious disease genomics and epidemiology, and in case of forensic. This picture is showing different technology using NGS as a platform. First of all, genomics. In genomics, when we talk, in this picture on the very left, you can see human and microbiome. So when we talk about human genomics, that means we are searching for point mutation, we are searching for insertion and deletions, and we can map whole genome or whole exon sequencing. That means protein encoding genes. In Human Genome Project, we came to know that there are 3.2 million pair bases. But among these 3.2 billion pair, only 1.5% are coding for the genes. Rest is junk DNA. So we can apply NGS in whole genome sequences, in whole exon sequencing, and we can analyze data for point mutation, small insertion and deletions, copy number variation, structural variation, and lineage identification. Not only in genomics, we can apply NGS for the identification or for the sequencing of complete RNA. That means DNA and RNA. Then not only genomics, epigenomics. We can know about DNA methylation, the DNA histone modification. Then when we come to the microbes, which is the study of microbes by using NGS, is called metagenomics. We can use blood, we can use different body fluids, and we can identify many microbes. Like we can do bacterial profiling, fungal profiling, microbiome profiling, and special mention to the antimicrobial resistance genes, which are very important when we are treating many infectious diseases like tuberculosis and in HIV infection also. This is a case report in which circulating DNA was sequenced by using NGS, and it was observed that there is tumor heterogeneity, there is variation is mutational profiling of primary and secondary deposits in patient in a case of lung adenocarcinoma. So it helps in the which led to the drug resistance. So it helps into the to gain the knowledge about the tumor heterogeneity, and which will help in the diagnosis. So this was a case of lung adenocarcinoma, and this sorry for the poor slide, but the message is conveyed that the patient, that in case of in those cases in which the clinical presentation is almost similar, NGS can help in definite diagnosis. This was the case report in which the patient was misdiagnosed as sarcoidosis, and later on the confirmed diagnosis of tuberculosis was made by using next generation sequencing. Next generation sequencing is also used to know the drug resistant genes, especially in case of tuberculosis and in case of HIV drug resistance cases. Then a very important aspect of using NGS, this is the diagnosis of rare diseases, rare genetic diseases. This is a case report from a patient in which diagnosis of a rare syndrome, Alström syndrome, was made at the age of 22 months. Patient presented with some macular degeneration. Patient was suspected for macular degeneration, and NGS was performed, and it was seen that there was a variant in the gene of ALSM1. There was a variant of ALSM1 gene, and so the diagnosis was made and the treatment was given accordingly. There are limitations of NGS. Millions of DNA sequences are produced. It is a very heavy data, and we require bioinformatics as well as expert data analysis for this NGS. So it involves the interpretation complexities. Of course, when we use technology, then we should have very strict quality control and standardization. So again, consideration in case of NGS, cost consideration, and ethical and privacy issues are there with NGS. So these are some ethical considerations which should be addressed, like informed consent, like data security, and we should know about private privacy. We should respect patient privacy, and also the facility, if we give treatment, then it should be available, it should be used with all the patients. Future perspective, as I told you, that data analysis is complex, so we expect that with the advancement in the artificial intelligence, it will be more easier, and secondly, it can be combined with other omics technology like transcriptome, proteomics, and metabolics. So this is the take-home message about NGS in precision medicine. We can see a horoscope here. So compare this horoscope with the human genome, human DNA, and we can see many planets, जिन्हें हम ग्रह कहते हैं, Rahu, Moon, Shani. These are the different genes, and if there is any variation, if there is any mutation in these genes, then it will lead to poor Grah Dasha or disease. And for the Shanti of these Grah, we do specific puja, and it is called precision medicine. So few words about today. Today is 21st April, and this is known as, this day is celebrated as National Civil Service Day in India. Thank you. Jai Hind.
First of all, congratulations, ma'am, for such a nice talk and explaining us the topic of NGS in such a simple way. Ma'am, I would like to ask, with so many advantages, is NGS going to replace fish, or will both of them act complementary to each other in diagnostic studies?
NGS is used not only in clinical medicine, it is also used in different aspect of different domains. For example, in agriculture field also. And I don't think that it is going to replace fish. It will be complementary to each other.
My doubt is that, ma'am, working in a teaching institute and actively reporting many oncosurgery specimens, but most of the institutes lack molecular lab setup. So how to cope up with that gap? Being a diagnostic pathology, how to shift to become a molecular pathologist?
At present, I think that because of cost, we can outsource this, or we can start with for example, in Subharti, we are doing metagenomics. So in that, we are doing at our place sample loading, and we are attached with we have outsourced that, and we got data from that. So you can start like this. And later on, of course, it requires very large infrastructures and very trained technicians and other things.
Thank you, ma'am.
Thank you.
Thank you, Dr. Anjali, for such an exceptional presentation. We are very grateful that we had the opportunity to learn from you. Now, I would like to call upon stage Dr. Saloni Nanda to come forward and present a token of appreciation to our esteemed speaker, Dr. Anjali Khare, and also for the chairpersons.
Let's move to our next topic, restoration, reconstruction and rehabilitation in oral cancer surgery, presented by our esteemed speaker, Dr. Prajesh Dubey, Professor, Subharti Dental College. The session will be chaired by Dr. Manu Sharma, Dr. Sandeep Kansal, Dr. Deepti Singh and Dr. Shashank Mishra. I welcome you all to the stage.
I welcome Dr. Prajesh Dubey, who is professor and very dynamic surgeon in Subharti Dental College. Very excellent surgeon. I welcome you. Please start with your talk.
Thank you, respected chairperson, delegates, all the faculty members. The topic of my presentation is reconstruction and rehabilitation in oral cancer surgery. So with time, significant improvement in the surgical management of the tumor of the oral cavity has been made. And the wide range of the reconstructive options are available, which improve both the quality of the life and the function of the quality and the function of the life of the patient undergoing ablative procedure for the oral cancer. Reconstructive approaches earlier were limited to the primary and secondary closure of the defect. Oral cripples poor speech and swallowing as well as the significant facial deformity characterized in anterior tongue and the floor of the mouth and the gum deformity. And many of the legendary surgeons, they advocate the use of the various loco-regional or free flaps for the reconstruction of such defects. At the same time, there was the development of an understanding of the growth and spread of the oral cancer, and the pattern of the spread to the regional lymph nodes were made, which reduces the lower rate of the mandibular resection, except in the condition when the mandible itself was involved, which in turn improved the deformity and the function of the patient. So when we are talking about the reconstruction of the tongue and the floor of the mouth, then the aim is to maintain the mobility of the residual tongue. As the bulky reconstruction, they limit the movement of the tongue, both in the forward direction as well as in the superior direction. So patient is not able to touch the anterior teeth or the lips or the palate. Second thing is to minimize the sensory dead space in the oral cavity. As the large non-sensate flap, they have with the use of large non-sensate flap, there is poor control over the saliva and the oral function. Third thing is the volume matching. So the adequate volume should be there, and the flap should be thin and pliable, so that it gives the resonance in the oral cavity and good speech articulation. So to achieve the aim, we should have the objective of the reconstruction of the floor of the mouth, as it prevents the inferior migration of the tongue into the inframandibular defect with the help of some fascia containing flap, like your anterolateral thigh flap or deep inferior epigastric flap, which has both the fascia as well as the muscle component. Angular tip of the scapula combined with the thoracodorsal artery flap can also be used in cases when there is associated defect of the mandible is also there. Second important objective is the recreation of the functional sensation with the help of the radial forearm flap, as it has the potential sensation where the patient can control the saliva. And also we can use the posterior auricular skin flap, which is based on the temporal artery, as the advantage it is soft and pliable, and also there is an inconspicuous scar in the donor area. When we are talking about the buccal reconstruction, the aim is to maintain the optimal mouth opening by providing the appropriate replacement of the height and the width of the buccal mucosa. But the controversy is still there. What is the optimal reconstruction of the combined effect of the oral mucosa as well as the external skin? So clearly the selection of the flap, it depends on the size of the defect, disease extent, and the patient ability to tolerate the complexity associated with the complex form of the restoration. So operator should choose whether the primary tumor has involved the commissure of the mouth or adjacent bone, or it has moved towards the base of skull. So in this scenario, we can use the pectoralis myocutaneous pedicle flap with a de-epithelialized segment for the reconstruction of the oral cavity as well as the external skin. Or we have also option of using the deltopectoral flap in combination with the pectoralis major flap. In the free flap, we can use the anterolateral thigh flap, which has both the component of the skin as well as the muscle. So it can use to reconstruct the external skin and the oral mucosa, while the muscle component, it is used to place over the reconstruction plate where the chances of the wound adhesion is more. So clearly, operator should assess the tumor if it has involved means in cases of the composite defect where the bone is also involved. So operator should assess what is the size of the defect, whether it is limited in the lateral side or it has involved the canine or condyle or opposite contralateral side of the condyle or extensive involvement of the whole mandible. Similarly for the maxilla, what are the vertical as well as the horizontal component involvement of the component. whether it has involved the maxillary antrum from the LUS, or it has involved the infraorbital rim, or it has involved the base of the skull. So almost so many options of reconstruction are available here also for the bone. And the non-vascularized graft, like iliac crest bone graft or rib graft, we can use, but they are not indicated in cases where the size of the defect is more than 6 centimeter. Almost they are always fail. Reconstruction plate is also one of the options which work well in the lateral defect. But usually the chances of the extrusion is more when it is placed in the central area, for example, in class 3 kind of the defect. And also the chances of the fracture of the reconstruction plate is more when in cases of the functional dentition where it crosses the native mandible. Recently, patient-specific implants are available where we can simulate the both contour as well as the TMJ function with the use of the patient-specific implant, where we remove the tumor with the help of the cutting guide, and we restore the area with the help of the patient-specific implant. Nice contour and form of the patient post-operatively. But the limitation in this with this patient-specific implant is again the wound adhesions at the junction where it crosses the mandible, and also the chances of the immunogenicity is more. Osteomyocutaneous flap, for example, pectoralis myocutaneous flap can also be used for the reconstruction of the mandibular defect. Though the current approaches to the mandibular resection has moved away from the alloplast to the free vascular bone graft, and the workhorse in this condition is the free fibula graft. The advantage of the free fibula is the long length of the bone up to 22 centimeter, reliable and predictable blood supply, and thin and pliable skin flap that is based on the peroneal artery and the vena competens. The disadvantage of this flap is the ankle instability and proprioceptive issue in the older patient, and also it is contraindicated with the peripheral vascular disease. The modern use of this flap is with the help of the virtual surgical planning, where we send the 3D DICOM data in the lab, where they send us the 3D stereolithographic model along with the cutting guide. So we can perform mock surgery outside of the patient, means outside of the operation theater, and accordingly we will bend the reconstruction plate. Intraoperatively, with the help of the second surgical guide, we can make the osteotomy cut and recontour or contour the osteoids, the harvested graft according to the reconstruction plate, and then we can place over for the reconstruction of the defect. With the help of this virtual surgical planning, the thing is that the advantage is the more predictable placement of the dental implant in the second surgery, and also it obtains the good facial contour. Some author use the prosthetic joint for the replacement of the condyle, while some use the bone flap itself for to restore the joint. But the prosthetic joint with the adjuvant radio and chemotherapy, they tend to extrude externally, or they might migrate towards the base of the skull. While in case of the non-prosthetic options, they have the poor outcome, especially in cases of radiotrismus, means difficulty in mouth opening will be there in those cases. For maxillary reconstruction, historically we use the obturator for the coverage of the defect. Again, similarly, like mandible, the prosthetic reconstruction, it depends on the extent and the location of the defect, both in the horizontal as well as the vertical component. Patient with a small defect, excellent result with the maxillary obturation, but defect that crosses the midline or have the vertical resection to include the suprastructure of the maxilla, like orbit or the base of this towards the base of skull, they do less well with the prosthetic reconstruction. So for that, the initial attempts were made for to reconstruct these defects with the help of the soft tissue like temporalis muscle flap, especially when they are located in the lateral and the posterior area. free tissue transfer is also available for the reconstruction of those defects with the help of the muscle flap or myocutaneous flap. But the problem with these flap, they cannot restore the dentition, and thereafter cannot we maintain the optimal facial form. So for patient in need of the bone reconstruction, to obtain the proper contour of the face, Browns, he used the iliac crest graft based on the dorsal circumflex iliac artery for the reconstruction of the vertical element of the maxilla. Similarly, for the restoration of the normal contour in the form, we can go for the patient-specific implant even without the bone graft in the alveolar area, and we can obtain the same contour and the function with the dentition with the help of these patient-specific implant, with the help of the removal as well as the fixed prosthesis. Also, one of the options is available when we have the scarcity of the alveolar bone after the resection, the zygoma implant, where with the help of the two zygoma implant on either side, with the help of the support from the zygomatic bone, we can rehabilitate the patient with the fixed prosthesis. Also, we have the dedicated maxillofacial prosthetic department is available here in the dental college, where we are restoring the defect with the both kind of the simple or the complex defect with the help of the prosthetic material, which give the good confidence in the patient and also the social acceptance for the patient. Thank you.
Very precise talk. The house is open for any query. Okay. I would like to ask,
sure, sir.
Can you tell us what are the important points we should take care during counseling for pre-operative preparation and post-operative care during restoration and in this group of patients? For the benefit of residents, yes.
Actually, sir, since it is associated with the facial area, which has the both impact on the function as well as the psychology of the patient, because the surgery is going to happen in the facial area, which overall affect the quality of the life of the patient as well as the function. So before going for the surgery, we should tell everything about the surgery, what is going to happen, and how we have to restore the facial form and the function. The psychological counseling is also very important, because once the disfigurement is there, so means patient should be aware before the surgery what is going to happen.
Very nice presentation indeed. I'd like to ask you, what's your take on putting an implant after irradiation of the bone? Do you want to be putting it after 6 months or any protocol like that?
Usually it should be delayed. Minimum is 6 months. But there are reports, there are so many reports are there which suggest that the chances of the osteoadenocrosis is going to happen even after 10 years. So, but basically those reports are, I think they are less in number. So we can wait at least for the 6 months, then we can put the implant.
So what's the protocol you are following here? How do you go for dental rehabilitation later?
As of now, we are using the patient-specific implant, where we take support from the bone in the form of the screw, not as a normal conventional implant like osseointegration. In conventional implant, we are waiting for the osseointegration, and for the patient-specific implant, we depend totally on the mechanical interlock between the PSI and the screw and the bone.
Thank you. Thanks a lot.
Thank you.
Again, thank you very much. Thank you.
Thank you, sir.
Thank you, Dr. Prajesh Dubey. Your insights delivered with clarity and enthusiasm were both enlightening and inspiring. I would like to request our chairpersons to present a token of appreciation to our esteemed speaker, Dr. Prajesh Dubey.
Hello. Let's move to our next topic, that is liver tumor treated non-surgically by RFA, TACE and TARE, presented by our esteemed speaker, Dr. Udit Chauhan, Additional Professor, AIIMS Rishikesh. This session will be chaired by Dr. Sachin Agarwal, Dr. Shishir, Dr. Nityanand Sharma and Dr. Faraz. Welcome, sir.
I would like to welcome Dr. Udit Chauhan. He is additional professor at AIIMS Rishikesh and he is MD DNB and PDCC in hepatobiliary intervention. He had a fellowship in intervention radiology through the Korean Society of Intervention Radiology, and he had diploma in European radiology as well as European Board of Intervention Radiology. He has various publication and chapter in book, and he having many awards and recognition like Seva Ratna Award, Him Ratna Award, Diploma of Indian College of Radiology and Imaging Award, and Teachers Day Award.
Thank you, Dr. Sachin, for such a nice introduction. I am really thankful for the organizers for inviting me for this talk. So to begin with, I will be talking on interventions in hepatocellular carcinoma. So as we all know, HCC is one of the most common tumors in the abdomen, and it has a notoriously very poor prognosis if it is not treated. Potentially curative options include surgery and resection, both of which can be coupled with interventional radiological measures if these are not immediately available. But only 20 to 30% of the patients will qualify for surgical treatment, be it resection or transplantation. So amongst the interventional radiological procedures that we have ablative techniques, which includes ablation with acetic acid or alcohol, radiofrequency ablation, cryoablations, microwave ablations, and irreversible electrophoresis. So basically all of these radiofrequency ablations, cryoablations, and microablations, they all deal with thermal ablations. Cryo, as the name suggests, it is ablating with the help of cooling. So this therapy is still not available in India, and we will not be talking about it. Irreversible electroporation, it has come up recently in India and is being routinely used in some of the higher centers, and it is costly at present, and the limit for tumor ablation is around just 2 centimeters. We will see what all others will do. In the intravascular therapies, we have TACE, we have transarterial embolization, hepatic artery infusion chemotherapy. This therapy is also still not available in India because the chemopod that is used for this is not available in India. And then we have TARE. So anybody who is intending to treat hepatocellular carcinoma must be aware of this classification system. This is the Barcelona Cancer of Liver Clinic classification system. I know the slides, it looks very clumsy, but we cannot go without it. So it classifies the disease based on the tumor burden, liver function, and physical status of the patient, coupled with use of AFP, ALBI, and Child-Pugh score. So you classify the disease into very early stage, that is stage 0, early stage A, intermediate, advanced stage, and terminal stage. So in early stage, the tumor is less than 2 centimeter. In very early stage, it is less than 2 centimeter. In early stage, it is single lesion, which is less than 3 centimeter, or maximum up to 3 lesions. Multinodular, which is beyond the stage A, becomes multinodular, but still the liver function is preserved. Advanced stage, whenever we have extrahepatic metastasis, whenever there is involvement of the portal vein, it qualifies as advanced disease. And in the terminal stage, be it any tumor burden, but the liver function is poor, that becomes terminal stage. So treatment options in intervention radiology, we have ablations, we have option of TACE, that is transarterial chemoembolization. These two are the major workhorse in intervention radiology. And whenever it is possible, always remember curative is resection and transplantation. When these two are not available in very early and early stage, we go for ablation, depending on the criteria that we will see just now, and TACE, depending again on the criteria. Systemic therapy is meant for patients who have advanced in disease and terminal stage, they will just be given best supportive care. So this VCLC classification is the recent modified that came up in 2022. It had 3 major modifications. The first one was to include tear. So tear was initially not included in BCLC classification. In this modification, it came up, and at present, the consensus is you use tear only and only in a single lesion which is less than 8 centimeter in size. That's why it is not widely used in routine practice. However, higher centers, paying patients, it is being done. The next thing that they came up was to divide this B stage into 3 other criterion, offering transplant to stage B patients also. And then another one was to include the TACE, to include the treatment stage migration. The treatment stage migration is basically you can change the treatment at any point of time. When you have given the initial treatment, you believe that treatment is failing, then there is a concept of treatment stage migration. So all these things have come up with new BCLC. So why we follow it? Because it tells you about the tumor status, it tells you about the liver function, performance status, and it is very well externally validated in comparison to all these staging systems. So in ablation, like I told you, we have chemical ablations, ethanol, acetic acid. We deploy energy, radiofrequency ablation, cryoablation, microwave ablation, and IRE. So what is the difference? So RFA and microwave both are going to deploy energy, heat into the tumor by agitation of dipolar molecules, and they are going to cause coagulative necrosis of the tumor. But the point is, the maximum area that you can cover with RFA is 5 centimeters, but with microwave you can go beyond 5 centimeters. They cause coagulative necrosis in comparison to irreversible electroporation. It causes apoptosis. So pathologically, both the treatments are different, and it creates nanoholes, and still we have treatment option available for less than 2 centimeter size. The treatment is clumsy, it is costly, you need to put multiple electrodes into the lesion, which itself is technically difficult for intervention radiologist. So now we know RFA is thermally mediated ablative techniques. It causes coagulative necrosis without damaging adjacent vital organs. So you have a safety margin of around 1 centimeter and you treat the lesion. So why we need ablation? Because only 5 to 15% of patients with HCC, they are eligible for resection. And we have a shortage of liver donors. So what to do? Do ablation wherever possible. So this is an example of a classical multi-tined electrode of radiofrequency ablation. There is a generator. These electrodes are put in the tumor and then they are opened up depending on the size of the tumor, and then they are ablated depending on the size of the tumor. So the best candidates are candidates which are tumors which are less than 3 centimeters. You can go up to 5 centimeter for HCC and up to 3 in number. Metastasis, you can go up to 5 in number. Then tumor should be completely surrounded by hepatic parenchyma. It should be more than 1 centimeter from the liver capsule. So these two were a relative contraindication in the past years, but now we will see how we have overcome these. Tumor should be away from any major veins, major hepatic veins and portal vein. We will see how we have eventually came above this also, and there should be no distant metastasis. So the last point of no distant metastasis still doesn't hold very good now, because now some groups in Korea and China, they have come up with a specialized protocol in which they say that you treat the primary tumor first by ablation or TACE, whatever is possible. And for extrahepatic metastasis, you can do different therapies like radiotherapies. If there is a bone lesion, you can do radiofrequency ablation of that bone lesion also, provided liver function is good. So these are some contraindications. Any untreatable, unmanageable coagulopathy, intrahepatic biliary radical dilatation, exophytic location, bilioenteric anastomosis, because when you do RFA in bilioenteric anastomosis, there are more chances of abscess formation, which is actually very difficult to treat at points. So in advances, we have RFA with balloon occlusion. We have subcapsular exophytic subdiaphragmatic tumor ablations and large tumor ablations. So this article came up in early 2000s, and it says we can ablate this tumor by temporary balloon occlusion of the veins. So they did in hepatic vein and portal vein, and they recommended that we can use them very safely and achieve good tumor negative margins. So this is a case of 74-year-old male with cryptogenic cirrhosis. You can see there is an arterial enhancing lesion in segment 4 showing washout. You can recognize that it is very close to the left portal vein. So what we did, through the transhepatic route, we occluded this portal vein with a balloon. That was intermittent balloon occlusion. We performed RFA. This is 4 weeks later. no enhancing lesion, portal vein flow is well preserved. So this is how we overcome the heat sink effect that was initially considered as a relative contraindication. So this is one of the very esteemed journal of radiology, and they have again said that you can do ablation in subcapsular SCCs and it should not be considered as a contraindication. This article again came up in early 2000 and they have also recommended the same. So this patient I did around 10 years back, a large subcapsular enhancing lesion in a CLD patient, definitely SCC. We created artificial ascites over the liver capsule and you can see the hypoechoic well-defined lesion, partially exophytic, placed 2 electrodes and ablated the lesion. Follow-up, you can see the lesion has decreased in size and there is no enhancement. So this was another article in 2006 that have recommended you can do intermittent balloon occlusion to avoid heat sink effect and treat these lesions with RFA. So what is the comparison? So there are 3 RCTs that have compared resection versus RFA, and they have recommended that whenever you have multinodular lesion, resection is superior in regard to overall survival. And whenever you have single lesion less than 2 centimeter, survival rates is almost same, so better to go for ablation. And in the future strategies, you can combine RFA with TACE, you can combine RFA with ethanol injection just to increase the benefit to the patient. So when you combine TACE with RFA, whenever we do RFA, the most common site of recurrence is in the peripheral part of the tumor. So when you combine RFA with TACE, because RFA, it deposits heat. Hyperthermia, it causes increase in the vascular endothelial pore. So when you inject drug through TACE with the RFA, you actually increase the deposition of the drug into the most peripheral part of the tumor. So chances of recurrence, they decrease. So this is what they have concluded, that you can do doxorubicin TACE combined with RFA. And this is case I did recently. You can see there is a lesion in the caudate lobe. So there are 2 electrodes that are placed in the lesion and super selective catheterization of the artery which is supplying the tumor. Similarly, at the same time, we are seeing on the ultrasound, the top image there, you can see well-defined deposition of the drug. This is the post-procedure CT, and you can see dense deposition of the drug in the tumor in the caudate lobe with this some staining in the surrounding portion also. So why we like RFA, why it is still alive and kicking? Because we have a long track record of radiofrequency ablations. It is used not only for liver, the cardiologists, they are using for ablation. In oncology, we have the experience with multiple organs like liver, kidneys and lungs. Recently, it is coming up for treatment of thyroid nodules also. And we have been doing RFA for a long time for varicose vein also. So we know about this modality, we know it works, and we know with the time it has become cheaper. So coming on to TACE, so basically TACE is transarterial chemoembolization. So you super selectively catheterize the vessels, which are arteries basically, which are supplying the tumor. You deliver drug, you temporarily block the artery and you come out. Why it is used for liver tumors? Because liver is the only organ which is blessed actually to have dual supply. We all know 80% comes from portal vein, 20% comes from hepatic artery. And HCC is a very special tumor because it takes all its blood supply from the hepatic artery. So our aim is to deliver the chemotherapeutic drugs via the hepatic artery into the tumor specifically, avoiding liver parenchyma. This avoids systemic toxicity and the drug concentration in the tumor is high, which kills the tumor cells. So the inclusion criteria, apart from what we will see, we have seen in the BCLC. Apart from that, some local inclusion criteria should be there. The first one is actually, there should not be hepatopedal flow in the portal vein because you are going to block one of the major inflow of the liver. If there is already hepatofugal flow, then it is going to harm the liver functions. Another thing is, LFTs should be within normal range. So you take a child status for this patient, we do TACE for up to score of 8. Bilirubin should be less than 2 and any general contraindications for angiography should not be there. We select the patients, so the best candidates are the ones who have good liver function, asymptomatic lesions without vascular invasion or extrahepatic strep. This is the same thing I talked, they have come up with a new protocol which is TATI protocol. you do TACE or ablation along with TKIs, along with immunotherapy in a patient with extrahepatic metastasis with preserved liver function. So they have come up with this model, and probably the last point doesn't hold valid as if now. So pre-TACE imaging, we always do a triple phase CT of the patient before doing TACE, because we need to see the anatomical location of the lesion, we need to see the number of lesions, we need to see what is the arterial supply for the lesion, any kind of arterial anatomical variation. Sometimes the right hepatic artery might be coming from the SMA. The operator might end up finding that artery if the preoperative TACE is not, TPCT is not available. You need to see the portal vein patency and flow direction. So there should not be tumor thrombus in the main portal vein, although branch thrombus is a relative contraindication. And exclude any kind of arterioportal or arteriovenous shunting, because if it is there, you are going to inject the drug somewhere reaching into the portal circulation or reaching into the heart and causing pulmonary embolism. So you admit the patient on the day of procedure, hydrate the patient, give some antibiotics, analgesics, and start with the procedure. So in TACE, we have two options. We can either do a conventional TACE or we can do a drug-eluting bead TACE. So the conventional TACE is the one that uses lipidol, that you mix with drugs. You create an emulsion of water in oil immersion. Around 4:1 concentration is what I use from past 5 years. And the other one is drug-eluting beads. So these beads are actually polyvinyl alcohol polymers, and there is elution of drug over these beads, and they say that when you inject them in the tumor, since these beads have a very defined pharmacokinetics, so the release of drug into the tumor is very constant. So you go as close to the tumor as possible, being super selective, and inject the drug into the tumor, and you block the feeding artery with some gel foam. Gel foam is a temporary embolizing agent, and you expect the vessel to be patent again after 3-4 weeks. So why lipidol? Because the first thing is lipidol, as I told you, we need to make emulsion. Lipidol is all fat. It is a lipid-based iodized oil. So it works as a carrier for the drug. Second, you need something that should be visible on X-ray. So lipidol is actually radio-opaque. So that is the second thing. Third thing is lipidol itself has some embolic effect. So that effect is actually utilized while doing TACE. So lipidol is radio-opaque. And another thing is when you have deposited the lipidol drug emulsion into the tumor, next thing is how do you monitor the response? So whenever the part of the tumor that contains this radio-opaque contents, you know that part has undergone necrosis, and you can easily follow these patients. So this is how it is done. You super selectively select the artery feeding the tumor, and you release the drug. The drug goes into the tumor. You keep on injecting till whole of the tumor is filled with the drug, and there is a reflux. So the drug-eluting beads, these are polyvinyl alcohol polymers. These are positively charged. The drug is negatively charged. There is elution of the drug, these beads with the drugs, and there is a slow sustained release when you inject them in the tumor. So this is how they look. The first image, that the blue one is the bead without drug, and the other one is the bead with the drug. It takes around 1 hour to prepare this mixture, and once it is there, then you can just go ahead and inject it, and again just block the artery with gel foam. So they come at present in India. We have 2 companies which are providing this. One is Merin and other one is Terumo, coming by the name of Liver Pulse. So they come in size of 1,000. From 100 to 1,000 microns, depending on the size of the tumor and the size of the feeding artery, you can choose the size and inject. So this article came in 2010, and they had compared the use of conventional TACE with DE beads, and they say that DE beads decrease systemic side effect and decrease rates of liver failure, and the objective response post-treatment was much better with DE beads as compared to lipidol. We will see now. So this is a case of DEB TACE. You can see this is a lesion in the right lobe with 2 satellite lesions. Angiography. You can see this large area of blush there. Injected DE beads. You can see that blush is gone, and in follow-up you can see that the lesion is appearing totally non-enhancing on MRI. everything about DE beads and taste, conventional taste was fine till this article came in 2019, I suppose, and where they have done a meta-analysis of comparison of conventional taste with depth taste, and they say that in terms of tumor response or survival, there is no superiority of depth taste over conventional taste. That is one thing. In terms of safety, they say that depth taste is associated with more liver injury, more myeloma formation, and more biliary injury compared to the conventional taste. And definitely the cost of depth taste is higher than the conventional taste. So this article that came in Cancer Treatment Reviews, it has completely put down the reputation of depth taste, and they have advocated use of conventional taste. So complication for taste, they include post-embolization syndrome that comes with pain, fever, and leukocytosis. It stays there for around 2-3 days. With supportive care, it goes away. Ischemic hepatitis, ischemic colitis with non-target embolization. Splenic infarction can occur when there is non-target embolization. We can have GI mucosal lesions. The drug is actually refluxing into the left gastric artery or into the GDA. Pulmonary embolism and infarction, I told you, if you are dealing with a case of arteriovenous fistula, shunting, so you are injecting the drug in the artery and it is all going through the hepatic veins into the heart and reaching up to the pulmonary circulation. Spinal cord injuries, sometimes unrecognized spinal arteries can be targeted with non-target embolization and leading to spinal cord injuries. And some cases of ischemic skin lesions, failure to recognize falciform artery, that is usually a branch of left hepatic artery, can cause these complications. So, what are the expanded indications of taste? So, as per the latest BCLC also, we have seen that whenever you can do a treatment stage migration, whenever ablation, surgical resection, all these things are going to fail, you can put in taste. So, if liver transplant is an option for the patient and liver transplant facility is available, but patient is in a waiting list, that happens in most of the times, you can do TACE as an early stage therapy to bridge the gap of the time between definite liver transplantation. The second indication is you are doing in early stage disease, you can combine this with RFA, and you can do sequential TACE with combination with RFA till you are waiting for a definite treatment. For a recurrent intrahepatic lesions, that is the same thing, treatment stage migration. You can do TACE, you can combine them with RFA if it is possible. And in advanced stage, if the liver function is there, like I said, you can still go for TACE. So basically this is the same thing with the slide. So if the patient is within the Milan criteria for liver transplantation, but patient is on the wait list, you can do a TACE and you give a bridge and then patient can go for liver transplantation. But if the patient is out of Milan criteria for liver transplantation, what to do? In that case, you can again do a TACE, you can combine that with RFA, try to downstage the size of the lesion, try to put the patient back into the Milan criteria, and then patient may go for liver transplantation. For intermediate and advanced stage, definitely you can go for TACE and again do a repeat TACE. You can combine that with RFA on demand. So response assessment. So for all the solid tumors, for most of the solid tumors, I would say, you do TACE, you do RECIST criteria, RECIST 1.1 for response evaluation. But for TACE, for HCC, you cannot do that because, like suppose you do ablation, the tumor size actually appears to be larger after a follow-up because you have done a successful ablation of a safety margin also. So we follow modified RECIST for response evaluation. Modified RECIST encompasses use of, you calculate the sum of only the enhancing portion of the tumors post-treatment. So that is the difference between RECIST and modified RECIST. And a dense tumor staining with lipidol means that there is necrosis into the tumor. So it has been demonstrated that lipidol deposition is a good prognostic marker for survival of these lesions. And because it has a long-lasting deposition, that means that there is tumor necrosis. The areas which are not showing deposition, that means either the tumor uptake was low or there were some other unidentified feeders into the tumor. So this is, I think, every diagnostic radiologist amongst us should know how to follow up the patient with TACE. So you can see the first one up there is no lipidol deposition. So you can have deposition which could be incomplete or complete. In both the types, we have a homogeneous and patchy deposition. So incomplete homogeneous deposition, incomplete patchy deposition, and complete homogeneous and complete patchy deposition. We'll see how. So this is an enhancing lesion. TACE was done. You can see this is a incomplete deposition. All of the tumor is not covered. Incomplete as well as patchy. So what is going to happen over a period of time? You can see in the third image there, the deposition is gone. So that means there is some tumor progression. And with the follow-up on the arterial phase, you can see again there is appearance of some enhancing portion in the tumor. So that means incomplete deposition means the treatment is going to fail at some point of time. Here you can see again enhancing lesion in left lobe, good lipidoid deposition. I think it is complete homogeneous deposition, sequential follow-up, no reappearance of the tumor. So I think this is the last slide, and any guesses what procedure has been done in this patient?
So I can see a plug has been placed, but I'm not sure for what. I think portal vein.
Something else? I will give you a hint. There are 3 procedures that are being done in this, that were being done in this patient. So this was a young patient with HCC. I think he was 35 years of age. Liver transplantation, as we know in India, it is still not available to each and every person. So we decided to go up with resection. Size of the tumor was just more than 5 centimeters. So first I did TACE. You can see there is some lipidoid deposition, that rounded thing over there. I did TACE. After TACE, after 3 weeks, you can see this branching opacity is there. I did a portal vein embolization. The reason was the patient was planned for extended right hepatectomy. So we did a right portal vein embolization following TACE. But after 4 weeks again, we found that there is no increase in the future liver remnant, even after doing these 2 procedures. So this plug, like you rightly said, it is placed in the right hepatic vein. And this procedure is known as liver venous deprivation, where you deprive the liver with all the circulations. So we have done TACE, we have embolized the artery, we have done portal vein embolization, we have done hepatic vein embolization also. And then there was, after all these 3, there was some increase in the size of the future liver remnant, and patient underwent surgery. Thank you.
Sir, how do you deal with subdiaphragmatic lesions? What is your approach for it?
So for subdiaphragmatic lesions, I think if you have microwave, that is the best option you have for ablation. If you don't have microwave, then you can create an artificial ascites. You can just put in a 5 French sheath and just put some saline or dextrose. I prefer to do it with dextrose. And then you can just ablate the lesion, because we are more worried about doing a diaphragmatic injury in this patient. Because generally, and at presently, I have started combining it with TACE. You do a TACE with the RFA on the same setting to get complete margins.
How much volume of dextrose you're using for creating?
That depends. You need to create around 1-2 centimeter of artificial ascites. So you can connect them with the pressure bag and with the sheath around the liver.
Okay. So one more question. Sir, how do you diagnose HCC? Like what problem I have is I get a reference for doing biopsy in patients in which they're having ascites, liver is cirrhotic. So how do you
So like if you follow the American Association, the Society for Liver Disease, they say you should you do not diagnose a HCC with biopsy until and unless both the cross-section modality are negative. So you don't diagnose a HCC with a biopsy. That is one thing. So the classical, the pattern is enhancement and washout. So if you are not sure on like triple phase CT, then you can go for a MR. If you are not sure on MR also, then in that cases you can see the status of the liver, and then maybe, like you said, there is ascites and all those things, then you can go for biopsy. But usually it is not needed.
So before
you can do, yes, we drain the ascites before doing a biopsy, and we plug it with gel form. The track, we always plug it with gel form.
Sir, is doing FNEC enough, or do you have to go for biopsy only?
I think the pathologist can say about that, but we always, I told you, we never do biopsy for HCC.
Correct, sir, that is
regarding the biopsy, actually biopsy is indicated only for the lyrid M M lesion or intermediate stage, Lyrite 4 or Lyrite M. Because in this situation, we don't know actually what we are dealing with. So biopsy is indicated only for the Lyrite 4 and Lyrite M.
So sir, the Lyrite M is basically, it is not HCC?
Not
because
HCC,
it is something
it's
else,
diabetic.
and definitely it has to be biopsied. Lyrites 4, because sir, these HCC they are not that fast growing tumors. They are slow. So even for Lyrites 4 also, if we see that if there is some enhancement, we correlate with PIVKA levels and AFP levels, we can go for ablation directly because there is no harm. If the liver is cirrhotic, we know even if we are dealing with a small dysplastic nodule or a small SCC not fitting into the criteria of LR5, it is better to go with ablation than doing a biopsy and all.
This plastic lesion could not be more than 3 mm.
No, it can be sir, up to 10 mm. We can have if we are having a doubt, because sometimes whatever the enhancing and washout criteria are there, they are best described for a moderately differentiated HCC. So if you are dealing with a poorly differentiated HCC or with an HCC with a portal vein thrombosis, you will not see enhancement, you will not see washout. So that is one of the drawbacks of Lyrites. In Lyrites, that the feature of LRM with TIV, it is basically all of them will turn out to be a poorly differentiated HCC with portal vein invasion.
Correct.
So that is one fallacy of using Lyrites.
Okay, one more question. When you are not interested in doing the trace or tear in the lesion 4 to 5 centimeter?
Trace or?
Trace or tear, whatever.
In 4 to 5 centimeter lesions.
Or when you would like to recommend for the directly surgery, not doing any intervention.
Sir, actually at my setup, every patient with every tumor, it goes to tumor board. So it is a multidisciplinary meeting. So all the things are taken into account. So wherever the lesions are up to 3 centimeters, so our aim is to do a ablation. 3 to 5 centimeter, definitely we try to combine it with RFA, TACE with RFA. And beyond that, we see the general condition of the patient, like that patient also. You combine TACE with portal vein embolization, plan for resection. And if it is not feasible, then we do multiple TACE 2-3 times.
Okay, what is the cost of RFA in your setting?
RFA, in my setup, it is free of cost. We have a machine, we have antennas that come in supply, so we do it free of cost.
In private setting?
I don't know. But what I can say is that electrodes come for around, I think 60,000-70,000. That is the cost of one electrode.
Okay, for the lesion less than 3 centimeter, it is better to do ethanol injection. It's a very cheap and it's a good.
So you can do ethanol injection, but ultimately you are going to end up with recurrence, and recurrence is very difficult to deal because you will have some puddles of contrast enhancement in different peripheral parts of the tumor. It will be very difficult to deal with that. And that is what happens because the perfusion of the drug is not similar in all the parts of the tumor. And itself, the tumor and the cirrhotic liver, all of them have different consistencies. So it is not, you can combine that with TACE, with this RFA, but personally we never do acetic acid or ethanol.
Ethanol injection,
Sir, thank you. That was very informative talk. I just want to know your comments about, as you said, all the patients are discussed in tumor board. So, which patients of hepatocellular carcinoma would you like to refer to radiation oncologists for SBRT?
So, I think that is a very good topic of discussion. So, whenever we deal with patients with thrombosis in the main portal vein, and a large SCC with main portal vein thrombosis, so whenever they get out of the criteria of TACE, so even the literature recommends there is a good response of combining them with a TKI. You do a EBRT with TKI, that takes away the same advantage that you do with a TARE. So TARE is not available at our setup at present because it's already costly also. EBRT is also not available because they are saying that there is, I don't know about much details, but the respiratory triggering and all those things, that is not available with them at present. But these patients are actually good candidates for doing a.
Yesterday we had a very informative talk by Dr. Shyam Singh Bisht on SBRT for HCC, and he dealt in detail. So I think the audience, those who were present yesterday also, they got a very complimentary type of overview about all the local therapies. And I'll be very happy to see Dr. Sachin starting TACE in our setup. Thank you.
Definitely in future with the help of Shashir and Dr. Udit, sir, we will definitely start.
We are already doing SBRT. We are, our RFA, we have also done one case of RFA we have done. Yes. So. Yes, lastly, as you said, it is free of cost in your setup, but I think as far as my experience is concerned, there is some cost prohibitiveness in TACE compared to SBRT. Do you want to comment anything on this? I mean, anyone?
I think conventional TACE, in my opinion, would be much cheaper than.
Conventional TACE, you can. We are doing it anywhere between I think 60,000-70,000 total in and out. Conventional TACE.
Conventional TACE, I think, much cheaper. Depth TACE will be much more expensive.
Look, there are no procedure charges. We don't have a procedure charge. So you have to only plan for consumables, and if the patient is even not affordable for that, we try to arrange. And we are doing we are participants of Emerald 3 trial also, so many patients are enrolled in that, so they get a complimentary procedure.
Hello. Very nice talk, sir. One thing, I have a question. As a radiation oncologist, we know one thing you said that motion management is not possible. Motion management is one of the most important aspects of giving SBRT. So here we are able to do both breath hold as well as gating mechanism for motion management. And another thing is that as compared to SBRT versus RFA, in SBRT we know what dose we are giving. So we have a virtual planning. Let's say we want to give dose more than 100 VED, which is curative dose. So we are able to have it. We can see in our system, we can see, we also do quality assurance test also to see if we are getting that more than 100 VED dose. But can you say the same thing for RFA as well?
Yes, definitely. The protocols for RFA are also designed. Like I told you, it is a very long used modality. So every system comes with a particular amount of power that you deliver to the lesion based on the size of the lesion. And they are impedance based. So whenever there is charring around the electrode, there is saline infusion, and you have to deliver that dose within the drug. It is not blind.
So you know what a temperature is?
We always know that is.
There is virtual planning for RFA as well. So is it there?
Virtual planning for RFA? No, we do it.
What is the degree of temperature you need for that ablation?
Degree of?
That what is the degree? What is the temperature? What is the thing?
That is all set up with the generator. That is all set up with the generator. Okay. We just need to know the size of the lesion. We select the electrode based on the size of the lesion. Our aim is to put it at the center of the lesion. If needed, we put 2, 3 or 4 electrodes also. And when you start ablating, you get a good, nice heat ball. So with that heat ball, you are sure you have covered the entire lesion with RFA, and post-procedure you can immediately do a CCT to find out if there is more enhancing positions, but usually it is not needed. You can do it under ultrasound guidance or CT guidance, whatever is good.
So for RFA, it is like size should be less than, ideally should be less than 3 centimeters or?
You can do it up to 5 centimeters, but the good results come with 3 centimeters.
And there would be one probe inserted or multiple probes can be?
That depends. You can, if you are dealing with a larger lesion, you can put more probes.
And if suppose there are...
Like the lesion I showed in that chordate lesion, I have put 2 electrodes. So because the chordate lesions are always difficult to reach, so putting 2 electrodes was giving me extra surety so that all of the part is covered.
And if it is, suppose there are 2 or 3 probes, and can we see what is the combined doses in between that area also?
So both the probes are connected to the same generator. Both the probes are actually connected to the same generator, and that generator is going to deliver the energy. So energy is going to come fixed. And I told you it is based on impedance. So whenever there is charring, they know, the probes know, the machine knows that already that tumor has been ablated.
Okay.
So it is impedance based. It is definitely dose based. It is not blind.
It is not blind. Thanks a lot, sir.
Thank you.
Thank you, Dr. Udit Chauhan. Your insights delivered with clarity and enthusiasm were both enlightening and inspiring. Now I would like to invite Dr. Asya to come on stage and present a token of appreciation to our esteemed speaker and the chairpersons.
At last, I would like to invite Dr. Anil Gupta, Associate Professor, Subharti Cancer Institute, for the valedictory address.
Hello. Thank you all of you. First, this is my written one, and before this, I would like to thank Dr. G.K. Ras sir, and he has attended from the beginning to till the end, and he has the endurance sir has, we can only think of. Thank you, sir. Ladies and gentlemen, distinguished guests, esteemed speakers, esteemed chairpersons, and honored delegates, we, the faculty and staff of Subharti Institute of Cancer Management and Research, would like to applaud you and thank you for taking time out of your busy schedules to make this conference a memorable one. We owe a debt of gratitude to the visionary leadership of Dr. Atul Krishna sir, our esteemed founder. The pious gathering was not possible without a formidable institutional structure designed by him, along with direct support of our EMS and DMS and EO, Dr. Krishnamurthy sir. Be it IT support, be it PPD department, Faculty of Fine Arts, everyone played their part. We would like to specially acknowledge Dr. Pintu Mishra sir, Dr. Trishla, Dr. Archita Kansal Tiwari, ma'am. Despite of holding multiple portfolios and responsibilities, she extended formidable support for this conference. Let us also recognize the work of our interns, whose participation enriched their learning experience and added immense value to our proceedings. And last but not the least, we would like to thank the person who provided tactical support and handled all the work behind the scene, Mr. Naveen Nehra, our operational manager. His dedication is commendable. Finally, I humbly apologize for any shortcomings that may have risen despite of our best efforts. We are committed to learning from this experience and endeavor to surpass our own standard in the future. In conclusion, I extend my heartfelt thanks to each and every one of you. Thank you one and all, and we may now proceed for lunch.
Please stay back for a moment. As we conclude this intellectually stimulating day, I would like to invite all of you for the group photo on the stage. Thank you all for your presence over here. Thank you. Please come to the stage for a group photo.